Sir?
Yes, we will start now. Okay. Good afternoon to all, good evening to all of you. Welcome all of you for this FOGSI ICOG combined with ISAR certificate course on infertility, that is in collaboration with ISAR, which will be on 3 days, April 23rd, 24th, 25. And the timing is from 4 o'clock onwards till 7 o'clock. And today we have we are graced with Dr. Parag Biniwala, chairperson ICOG, and secretary, and Dr. Sarita Balravo, who is the brainchild of this. And also we will be joining by the FOGSI president, Sunita Tandulwarkar madam. And already we have ISAR president Amit Patki here. Sir will be in between his busy schedule is traveling in short while for an international conference. He is kind enough to join. And also we hope Secretary Dr. Asha FOGSI and other ICOG dignitaries will be joining. And my co-conveners are Dr. Seema Pandey for the second day and Dr. Pradeep Tambe for the third day. And today's coordinator is Dr. Angita Srivastava. And with this, I welcome Dr. Parag Biniwala, chairperson ICOG, to say a few words. Sunita madam will be joining shortly.
Can we start the inauguration?
Yes, yes.
So we welcome ICOG chairperson Dr. Parag Biniwala. I think Sunita madam
You
will
must
join.
stop sharing.
I think we will as a formal introduction.
Don't waste time in that.
Okay.
Good evening. I bring greetings from ICOG, and it's indeed a pleasure to address you all as the chairman of ICOG for this 3-day certificate course on infertility. And this will be conducted in association with ISAR. At the outset, let me thank the president of ISAR, Dr. Amit Patki, secretary, Dr. Asha FOGSI, and the entire team for agreeing to collaborate with ICOG for this 3-day course. My 3 voting council members who are the conveners have put in a lot of effort to have this program in place. Dr. FOGSI Lewis, Dr. Pratik Tambe, and Dr. Seema Pandey. So I'm looking forward to interesting learning session. I understand it's a big challenge, and day by day we are facing more and more complex issues. So these 3 days will certainly help all our clinicians to tackle these situations with rather ease. So thank you all for joining, and happy learning, everyone. Thank you. Tessie, you have to unmute yourself.
Sorry. Thank you, Dr. To ICOG chairperson Dr. Parag Biniwala for the blessings and words of wisdom. I now call ISAR president Amit Patki sir for giving his advice.
A very good evening to you, and I bring you greetings from ISAR. We are at ISAR. We are honored to be associated with FOGSI and ICOG. FOGSI, with its large member data, is a good platform to promote educational activities, and ICOG being the academic wing. I would like to thank Dr. Sunita, Dr. Parag Biniwale, and Dr. Sarita for getting ISAR into this 3-day bonanza, as I would say, for infertility learnings. I've looked at the program for 3 days, and I think it is a very well devised and orchestrated program, and for which I would like to thank the conveners, Dr. Fessy Lewis, Dr. Seema Pandey, and Dr. Pratik Tambe, all three who happen to be managing committee members and office bearers at ISAR. I also take this opportunity to thank the coordinators, Dr. Ankita Srivastav, Dr. Anu Agarwal, Dr. Monica Singh, and the MOCs, Dr. Aarti and Dr. Aurora. I think we are going to have a great 3 days, and I'm sure at the end of each day, the MCQs will make you understand how much of it you have picked up and try and improve your practices in management of the infertile patient. So with these few words, I again would like to thank the ICOG office bearers and FOGSI for collaborating with ISAR. Thank you.
Thank you, sir, for that words of wisdom. I now call ICOG Secretary, Dr. Sarida.
Yeah, hi. I welcome everyone, and I think I will also be doing a welcome on the last day. So I just take this opportunity to wish this course all the very best, as today is the first day.
Oh, okay. Thank you, madam. I think Sunita madam has not joined. I think we will that we can go ahead with the sessions, no, sir?
Yes, and before you go ahead with the session, just let everybody know that attending all 3 days is compulsory, and of course you have to attempt the post-test. We have done away the pre-test part, but post-test is something compulsory, and one has to secure at least 50% mark every day in order to get a certificate from ICOG, and it will be you will receive an e-certificate from the office within 1 month. So this is some important messages for all the delegates, because we keep on getting calls from various delegates who are asking for certificates, but these are the prerequisites, and then only you will get a certificate. Please go ahead with the.
As an overview of the first day, I think first day we have that male infertility and IUI, and the second day we have the female factor infertility and fertility enhancing surgery, and third day we have the advanced IVF and advanced ART. So in today's session we have got three sessions basically. In the first session we have got talk by how to interpret semen analysis report by Dr. Chaitanya, then how to approach azoospermia and OAT by Dr. Fessy Lewis, the ovulation induction for IUI by Dr. Kedar, and the second session we have the talks on semen preparation techniques for IUI by Dr. Krishna Chaitanya, medical management of male infertility by Dr. Kunjumaidin, genetics in male infertility by Dr. Veronica. At the end, after the 2 sessions, we'll have the interesting case scenarios, IUI case scenarios, which has been moderated by Dr. Deepak Goenka, and expert will be Charmala and Dr. Raki Singh with expert panel members. And after that, we'll have a post-test, as our ICOG chairperson, Dr. Parag, told, and that we have to have attendance in all the 3 days, and all the 3 days post-test, we must get 50% mark. Then the certificate will be issued. So with this, I hand over the session to introduce the chairpersons of the session 1 to the coordinator, Dr. Ankita Srivastav.
Thank you, sir. As we start day 1, we begin the first session. I invite the chairpersons for the first session. Dr. Nimish Shalat, Sir is board reproductive microsurgery and from Kiel School and Gynae Endoscopy, and current designation holder of Director, Gujarat Institute of Reproductive Medicine, Sri Nandan Hospital and Shalat Hospital, Surat. He is also visiting professor at various Gujarat University, and he has also won the World Lifetime Achievement Award for pioneering IVF technologies. Thank you and welcome, sir. I also welcome Dr. Anju Soni ma'am. She is Vice President FOGSI 2026 elect, President IMS from 2024 to 2025. She is Secretary General IMS from 2022 to 23, as well as she has various accolades to her name. She's HOD Gynae and Obstetrics, Sony Group of Hospitals, Jaipur. Welcome, madam. I also welcome Dr. Ratna Agarwal, ma'am. I welcome Dr. Ratna Agarwal, ma'am. She's Chairman for Embryology National ISAR 2020 to 2022, as well as Vice President of CG Chapter of ISAR 2020 to 2022. She's past Joint Secretary cum Treasurer of Chhattisgarh Chapter of ISAR and Organizing Secretary for Organizing ISAR Conference in 2012 at Raipur. She has various accolades like ASRM Certified Embryologist and Life Member of Alpha Scientists in Reproductive Medicine, ISAR and IFS. Welcome, ma'am. I request the chairpersons to kindly introduce the speakers for the day.
Good evening to all. I would like to invite Dr. Chaitanya Sembekar, who is the first speaker of this session, who is going to talk on the important topic, how to interpret semen analysis report. Please display the CV. Okay, thank you. Dr. Chaitanya Sembekar is the founder, chairman, and MD of Omega Hospitals Private Limited, Nagpur. It's a 100-bedded single specialty state-of-the-art hospital in Nagpur since 1997 and attached to Datta Mega Institute of Medical Science for Obstetric Services. Past President of Nagpur OBGY Society, President OM Charitable Foundation, Vice President Sebankpur, an organization for medical students, member of PCPNDT Committee, Nagpur Municipal Corporation.
And it's okay, I think.
And also
I'll
headed many presidents of many society. I welcome Dr. Yeah.
Thank you, sir.
Chaitanya, it's very nice that you're going to talk on some very, very important topic,
Thank you, madam.
semen analysis, which is very, very often first step basically when we talk of male fertility evolution.
Right.
And interpreting correctly is requires a clinical insight for everyone. And today I'm sure that you will demystify the
Then before starting, we don't have pre-test, we have post-test at the end of the day, and all talks is try to finish in 15 in the allotted time. Thank you.
Chaitanya sir, you are muted.
Unmute please, Chaitanya.
Yeah. So thank you very much. Thank you, FOGSI, for giving me this wonderful opportunity. I am going to discuss a very basic topic, and that is the interpretation of a semen analysis. And I'll go very fast because this is a master class and I'm supposed to teach you the basics about the semen analysis. It is very important because this is as Anju Madam has said, this is the first step for as far as the male infertility is concerned. And I will ask you a few questions which you are supposed to answer at the end of the talk. What is the incidence of male factors in infertility? Second question is, what is the lower limit of normal total sperm count as per WHO criteria? And what is the difference between a man and a woman? And this last question answer I'll give you at the end of my talk. So what an oocytes want? Oocytes, they want only one sperm, or jo jita wo sikandar. So if only one sperm is required, then why do we require so many sperms? There is a saying in the corporate world which says that behind every successful man, there are many persons or many men. And these men, they help a man to go to the top. So there are many people working behind the scene. Similarly, as far as the semen count is concerned, you require only sperm, one sperm to go inside the oocyte. But for pushing that sperm inside the oocyte, you require many sperms. And unless that number is achieved, you will not be able to get the conception. When the person enters into your OPD, from the looks, you will be able to see, and you can actually go for the flash diagnosis. What is flash diagnosis? You come to know about the problem depending on the looks of the patient. Like suppose a husband comes to you and he is thin and he is abnormally tall, then you think about some genetic problem or chromosomal like Turner syndrome. If the patient is too obese, then you think that probably obesity is the cause. If he is alcoholic, then he's a chronic smoker, then immediately you come to know that he is a chronic alcoholic or a smoker from the smell. And if he is masculine, and say typically this is a new generation young boys who are attending gym and they are taking anabolic steroids. They will never disclose this, but then you come to know immediately from their looks that the masculine person, a bodybuilder, and probably he is having problem with the steroids, and that's why there is a problem with the sperm count. Now, our problem is, as a gynecologist, we ignore male partner. We do not take proper history. We don't do examination. We should have a protocol for the examination of a male partner as well. So you should give time, privacy to the patient. You should talk to them, take proper history, and do semen analysis from a proper person. Whatever I say, मेरी एक चीज आप बिल्कुल ध्यान से सुनो. Semen analysis from a proper person means a person who is actually trained in doing semen analysis as per WHO criteria. Then you have to take opinion sometimes of sonologist, urologist, or sexologist. You should take opinion of an expert if required. Now the incidence of the male infertility. As I told you during our college days, where I 92, 90, 91, 92, I joined for MS Gynec, and that time the incidence of male infertility was only 30%. We were taught that incidence is 30%. Now the incidence has gone to 50 to 60%. So the incidence is rising. The question is, where have all the cowboys gone? Why this semen count is falling rapidly? And this is the question which needs to be answered. There are many reasons for it, but it is said that the semen count is falling so rapidly that sperm drop could make humans extinct. This was the news in the Gulf Times, Gulf News, which says that probably the sperm count may drop so drastically that humans may extinct. And this is a possibility. Therefore, you should be careful and you have to take care of your body, and the lifestyle is also important. It is said that nothing succeeds like normal semen analysis report. If you have a patient whose semen count is 100 million plus, I call it elite club of 100 million plus semen count. That means there is no problem, absolutely no problem, except for some situations like erectile dysfunction, where some patients may have problem in spite of having very good semen count. But otherwise, good semen counts, you don't have to see for the male partner. There is absolutely no problem. Now, as far as semen analysis is concerned, you should know few things. It is the most controversial thing. It is inexpensive. And there is a myth that it is very simple and easy to do, but it is done by poorly trained technician. Many DMLT persons are doing semen analysis for 100 rupees. And therefore it is said, my dialogue, you all should remember, very easy to do this test badly. So this is a problem. It is very easy to do this test badly, and therefore get it done from a proper person. Some points which you should keep in mind. One thing is that you should do at least 2 tests so that you know that the semen count is normal or abnormal, whatever. So you should do 2 to 3 tests, but at least 2 tests. And this test should be done 1 month apart. And the parameters should be within 20% of each other. Abstinence is a very important issue, and abstinence should be, it is said that it should be from 48 hours to 7 days. But there are some special interest group which say that more the abstinence, more is the problem. Therefore, the abstinence should be optimum, and the optimum period is of 72 hours. Then you should ask them to give them some special instruction while giving semen analysis report, or while giving the sample. They are supposed to give it in a wide mouth sterile container, and they must wash their hands before giving this sample. They should not use any condoms because they are containing spermicidal jellies, and no home collection. Ideally, they should collect it in the semen collection room, and there should be done not by coitus interruptus, but ideally by masturbation, because the initial ejaculate contains important factors which are essential for the semen analysis report. Analysis should be done within 1 hour, and the semen should be kept in the ambient temperature, not in the refrigerator, because I know some patients, they collect it at home, they collect it at night, keep it in the refrigerator, and they come next day morning, they're taking the same. So these are the practical points, but you all should remember that ask the patient, give them instructions, that these are the instructions which you must follow before giving the semen sample. Now the next point is how to do the counting. The counting is done either by Newbar chamber and macular chamber. We need not go into details because I am supposed to do the clinical analysis of the semen analysis report, or clinical things which are important. But the counting is done by either Newbar or a macular chamber. This is what you should know. Then, as soon as the semen is collected, you see the macroscopic appearance. It is usually homogeneous, cream or grayish in appearance. Typically, gray color appearance of the semen is important. If it is of longer abstinence, then you will get a yellowish color. And if there is blood, you will get red, or RBCs are there, then you will get red color semen. Or if it is jaundice patient, then you may get yellow colored semen. It is maybe it is sometimes very clear and viscous. And if it is a clear semen, that means it is a pre-ejaculate from the corpus glands. That means it is not containing the semen, but it is containing pre-ejaculate and not a semen. So very clear sample is also not expected. Now you ask the allow the semen sample actually liquefy, and this should be done at 37 degrees for 15 to 30 minutes. The liquefaction time is 30 minutes. If it is more than 30 minutes, then you have to think of some problems like either abnormal prostatic functions like infection in the prostate, or seminal vesicle, or ejaculate duct, or some unsuitable container, or maybe the patient has done frequent ejaculation. So this may lead to more liquefaction time. Then at the same time, you have to check for the viscosity after liquefaction and the odor. Individual and subjective point is odor, because sometimes you may not be able to get proper analysis from the odor, but you should be able to differentiate this semen sample from a urine sample or a pus. If there is a pus putrefaction, then you will get typical putrefaction odor, or if it's a urine sample, you may get a typical odor of the urine. So odor also gives you some clue that there is some problem somewhere. Now the volume. Volume is important because there is something called as total motile sperm count, and this TMSC requires to have a proper volume analysis. The volume nowadays is said to be 1.4 to 4 ml. If it is less than 1.4, it is considered as low volume, and if there is no semen, it is called as aspermia. Hypospermia means less than 0.5 ml. It can be because of ejaculatory duct obstruction, or seminal or vas malformations, or congenital absence of vas difference, or retrograde ejaculation. Hyperspermia is where the volume is more than 6 ml. It can lead to sperm dilution. These are the things which you all should keep in mind. And if there is a blood in the semen, then think of either infection or inflammation or tumors or polyps or excessive masturbation or some obstruction at the level of ejaculatory duct or prostatic infection or a jaundice. So these are the causes of the blood or hematospermia in the semen. pH is also important, and we always see the pH. You should remember one thing, that whenever you do the semen analysis and get the report, you should make it a habit to see the complete report and read the complete report, because you may miss important points. I'll tell you that as I discuss more about the semen analysis. pH is normally 7.2. If it is more than 8, then that can be because of acute infections like acute prostatitis or vesiculitis. If it is less than 7.2, it can be because of chronic infections. It may go to as low as 6.6. And pH less than 7 is considered as a problem related to ejaculatory duct, maybe obstruction in the ejaculatory duct, or where cases where the prostatic fluids are secreted, and it may be because of urinary contamination. So around 7.2. Then second is count. The count, there you see various numbers which are there now available. 2000 WHO criteria, 2010 criteria, and 2021 criteria. And we are now following 2021 criteria. That is the latest criteria by WHO 6, that is called as WHO 6 bulletin. And here it is said that count should be more than 16 million per ml, and total ejaculate should contain more than 39 million of sperms. So that is considered as the lower limit of normal. It is important. There is an emotional angle to it. You should never say that you cannot father a child. And if a partner comes to you and if there is azoospermia, you should do the repeat analysis. And not only repeat analysis, you should do centrifugation of the sample at 3000 RPM for 15 minutes, desuspend the pellet, and again see if there are any sperms in the pellet. If there are few sperms, like less than 1000 sperm in that sample, that is called as cryptozoospermia. So in a cryptozoospermia, you get some sperms, and that is something where you have actually the ray of hope, where you can think of going for ICSI in such patients. And so always remember that do not label a patient as azoospermic unless you do the semen analysis, and then you can label it as a azoospermic. Next is motility. And as far as motility is concerned, there is some controversy. Initially in 2010 criteria, it was said that only progressive and non-progressive motility should be mentioned in the report. But now they have said that similar to the 2000 WHO criteria, that is WHO 4 criteria, 4 grades of motility should be mentioned, because it is important, because you should know whether the motility is grade 4, that is rapid progressive motility, which is the progression of sperm at the rate of 25 millimeter per second, whether it is slow progressive motility, that is called as grade 3, where it is 5 to 25 millimeter per second, whether it is grade 2, that is poor to moderate motility, or whether it is grade 1, which is also called as weak motility, or only twitching of the flagellar movement. So only the sperm is seeing seeing twitching movement of the sperm is seen, but there is no motility. That is called as grade 1. So grade 4 is rapid progressive, grade 3 is low progressive, grade 2 is poor to moderate progressive, and grade 4 is non-progressive. And these are the categories. Grade 4 categories should be mentioned in the semen analysis report. This is an important point. The next point is the vitality. And अभी ये मेरा dialogue आप हमेशा ध्यान में रखना that all motile sperms are live, right? All motile sperms are live, but all non-motile sperms are not dead. Some of the non-motile sperms are also live, and that is why you should look for the vitality of the sperms. And as far as vitality is concerned, there is a staining test called as eosin-nagrosin staining test. But the better test is a sperm function test that is called as FOGSI test, which gives you idea about the vitality of the sperm. It is said that as per WHO 6 criteria, 54% of the vitality should be there. How much should be the vitality? 54%. Next is the morphology. And for this, there are Kruger's criteria. Here you see a tail and a complete sperm is seen. And when you see the complete sperm, then you should be able to actually find out whether there is any defect in the sperm, and that is called as teratozoospermia. So if there is a morphological defect in the sperm, it is called as teratozoospermia. And this sperm defect should be more than normal sperm should be more than 4% as per the strict Kruger's criteria. So these are the various defects which you may get when you do the semen analysis report, and the Kruger's criteria should be strict. Kruger's criteria should be 4%. It should not be more than 4%. That is about the structure or the morphology of the sperm. One very important practical point you all should remember that globozoospermia, that means globular cap or head of the sperm, and necrozoospermia, that means dead sperms, can never conceive. So a patient with globozoospermia and necrozoospermia can never father a child. And remember this, always remember this, if you are appearing for any exam, you will get this question. Globozoospermia and necrozoospermia patients cannot father a child. Something which you all should remember. Apart from the spermatozoa, you may get other cells in the semen sample, that is WBCs. And WBC count, if it is less than 1 million, it is okay. But if it is more than 10⁶ million, that means the patient is having male accessory gland infection or MAGI. And therefore, you should do peroxidase staining to see whether there is any infection. If you get the leukocyte count more than 10⁶, then you should go for semen culture to confirm that there is a semen infection, and culture sensitivity will give you idea about the antibiotics to be given. So there are various spermatids and spermatogonia which you may get along with the sperms in the semen sample. Sometimes the sperms are attached to each other. That is called as agglutination of the sperm. And this sperm agglutination can be non-specific or specific. It is a specific agglutination which is important, and it is because of the anti-sperm antibodies. So always think of immunological causes if there is a
Sorry to interrupt you, sir.
Yeah.
Your time is up, sir.
Yeah, give me 2 minutes, I'll finish. Give me 2 minutes.
Okay.
This is the last 2-3 slides. So agglutination means the sperms are attached to each other, and that means there is some problem, immunological problem, which is the cause of the infertility. Now we are on the last 2 slides. As I told you, there was a WHO 4 criteria, 2000 criteria, then came the WHO 5 criteria, that is 2010 criteria, and now we have WHO 6 criteria, which is called as 2021 criteria, and that is the latest criteria. And whatever I have told you about the pH, about the volume, about the morphology, about the structure, all these things are mentioned in WHO 6 bulletin of WHO, which you all must read to get the idea about the WHO counts and WHO categories of semen analysis. And last but not the least is total motile sperm count. Nowadays, people talk about total motile sperm count. You all should know this. It gives you a better indicator of a male factor of infertility, because it will not only consider the sperm count, but also consider the volume and the motility of the sperms. And therefore, it is the ejaculate volume multiplied by density multiplied by motility divided by 100. And this total motile sperm count gives you better idea about the possibility of conception with this patient. But remember, this is the last point, that this semen analysis alone cannot predict the fertility of a person, and therefore there are some advanced tests which are there, and these tests are called as sperm function test. And WHO 6 says that there are extended tests which include DNA fragmentation index test, which is important, and there are also advanced tests which also includes some tests like CASA, which have been included in the WHO 6 bulletin as an advanced testing. So finally, we all should remember that male factor is an important factor. The incidence is 60%. You must know how to evaluate male factor. The first step is to actually look for the proper semen analysis from a proper person and never ignore the male partner. That is a take-home message. And the answer to my last question is, what is the difference between male and a female or a man and a woman? The answer is vast difference. Thank you very much.
Dr. FOGSI, is there any time for anything? Because I would just like to ask one question, that would you recommend repeating borderline report after lifestyle changes or directly proceeding to the interventions?
No. We must actually focus on the lifestyle intervention, because these are the we all know that the major cause of declining sperm count is the lifestyle problems with the lifestyle, obesity, and alcoholism, and all these factors are playing a crucial role. So we must modify the lifestyle.
And do you correlate semen parameters with hormonal profile and of course history in decision making?
Yes, I think my topic was related to semen analysis interpretation, but it is not only the semen analysis interpretation. As I told you, as the patient walks into the OPD, you come to know about the problem associated with that male partner, and also take proper history. And that is what we gynecologists, we don't do it properly. We should always give equal importance to the male partner. I have seen many doctors, they ask the male partner to sit outside or stand outside. They don't allow them to come inside the chamber. That is wrong. We all must take proper history, do examination from a urologist if it is required, and do hormonal investigations as well if it is required.
Thank you,
I think I've been told that it's in master class, the question answers through the chat box.
Okay.
Right.
Because otherwise sessions will get postponed.
Great. Thank you so much. Thank you, FOGSI. Thank you.
Thank you, sir. Thank you, sir, for your clear information regarding how to interpret semen analysis report. Now we should move to our second talk.
So without wasting any time, I would like to introduce Dr. FOGSI. And I don't think Dr. FOGSI requires any kind of introduction.
I will start now, madam. Okay.
Yeah.
Thank you, madam.
He has been VP and he has been actively participating as a fertility specialist, and we all know he's a real teacher of teachers. So over to you, Dr. FOGSI.
Okay, thank you, madam. I think the topic I'm going to speak is how to approach azoospermia and OIT. I think male infertility prevalence is 50% of couples suffer from infertility. In male factor accounts for 30 to 50%. If you see that either combined or together, nearly 50% of patients comes with male infertility. And if you want to know anything about male infertility, we must know about the HPG axis, hypothalamus-pituitary-gonadal axis. That is from the hypothalamus, GnRH is produced in a pulsatile fashion from the pituitary. FSH and LH is produced. FSH act on the Sertoli cell to produce a sperm, and on the LH on the Leydig cells to produce a testosterone. And when the testosterone primed cells, only the Sertoli cells usually act to that Sertoli cells only usually the FSH will act. And this is just for to know how the pictorially how the HPG axis, hypothalamus-pituitary-gonadal axis, works in the males. So as you all know, sperm is produced and it is transported into the through the from the testis to the epididymis, and through the vas, it travels through the ejaculatory duct, and it comes and where the seminal vesicle joins and comes through the penis. So, evaluation of male infertility, as Dr. Chaitanya told, the semen analysis is the most and prime factor for infertile couple we have to see in the male factor. And what is this azoospermia? Azoospermia is no sperm in the ejaculate. So how will you confirm this diagnosis? To confirm, you have to repeat the semen analysis after 4 weeks, and we must rule out any recent febrile illnesses, because sometimes viral infections will produce transient abnormality in the sperm parameters, and exclude ejaculator factors. That is the thing we have to always make sure before coming to a diagnosis. And also azoospermia may be due to either no sperms produced by the testis, or quantity produced is not enough to be present in the ejaculate, or can be obstructive azoospermia. I'll come to that separately. So always you must have a differential diagnosis of impotence or ejaculatory problems, like whether it is a retrograde ejaculation where the patient has got an orgasm but sperm is not coming, or it may be pure anejaculation. That has to be ruled out in cases of azoospermia. And always you must look into the history in that patient, clinical examination, and hormones, and ultrasound if needed, testicular biopsy indeed. I will come to that separately. So the most important, we have to start with the childhood and development history, whether there is incidence of undescended testis is there, testicular torsion was there, mums with orchitis is not just mums is not enough, whether other surgical history like hernial surgery, when was the onset of the puberty, and secondary sexual characters that we can see by the when the patient individual started shaving, or how the pubic hair is there. And coming to the most important is clinical examination. When you are dealing with infertile patients, try to learn for the basic male evaluation by yourselves, by the gynecologist has to see that. And here we have this MCH course. We train all the people who come for training and MCH to do the basic male examination by the, it is a part and parcel of the infertility evaluation. You have to see the testis, whether it is sizes, how it is, whether it is size, the consistency, epididymis is it distended, and vas if it is absent, thickened or beaded. Historical representation of the how the the anatomy. And we must also look for other phimosis, paraphimosis, hyperspadiasis, or presence of or clinical evidence of the varicocele or hydrocele hernia in the patient. This is a simple, just 5-minute examination. We can roll out all these conditions. And semen, what the volume semen analysis, where the persistently volume was less, whether pH, how it is acidic or alkaline, and fructose, whether present or absent. So in azoospermia patients comes in addition to that, we have to look for one hormone, that is FSH. FSH, if it is more than 8, it denotes it is non-obstructive azoospermia, or if it is less than 2 or 3, it is hypogonadotropic hypogonadism. And protocol for evaluation and the testicular size, if it is atrophied, whether the size is small or low volume, as I told. And if it is atrophied testis, we must correlate with the FSH. Usually the FSH will be high, and biopsy shows usually the atrophy, and donor insemination adoption will be the only option if it is a atrophied testis with the high FSH value. And if it is a low or normal volume, we have to make sure where it is not hypogonadotropic hypogonadism, and that is the only indication where the male medical treatment is part of that. Dr. Kunjumudin will be talking in subsequent talk. Or if it is a more than 7 or 8, it can be most of studies tell it as 8 also, known whether it is non-obstructive azoospermia. So that is the importance if it is especially in the low or normal volume testis. And it is if it is hypogonadotropic hypogonadism, usually it is rare, but usually the testis can be low or normal value. FSH will be low. It is the only condition for medical management, where we have to start with HCG and then add with HCG with gonadotropins. That Kunjumudin will be talking about that. Then coming to the obstructive azoospermia, we have to see where the obstruction is. Usually the FSH will be between 3 and 8. And usually we must know the obstruction can be with the absence or obstruction in the vas or the retinal testis area. So we have to clinically see the patient whether the testis size is usually will be normal, epididymis is distended or not. And in obstructive azoospermia, usually the can be the volume can be less than 1 ml, where it is fructose will be absent acidic pH. It is a rare condition, not very common, but usually it will be normal ejaculate with ml more than 1 ml with alkaline pH and fructose present. And then in those patients, epididymis, we can retrieve the sperm from the epididymis or the testis. And if it is if it is a low volume, we have to always rule out whether in vascular also sometimes the volume can be low. And usually, as I told, no, the FSH will be usually 3 to 7. And vasal, we have to see whether it is discontinuity or thickening in the vas is there, epididymis is distended or not, and sometimes it can be retitestis obstruction will be there. So in those patients with obstructive, we can get normal testicular biopsy, normal spermatogenesis report. But in non-obstructive azoospermia, usually the biopsy report can be testicular atrophy, maturation arrest, Sertoli-Cell-Onley syndrome, or hyperspermatogenesis. So the options for azoospermia is medical management, surgical, or ART or ICSI procedure. Medical management at all, it is indication is hypogonadotropy, hypogonadism. Surgery for ejaculatory duct obstruction, I told you it is very, very rare condition. And for vasal obstruction or epididymal obstruction, usually the surgical results are not good, and you need highly skilled and prolonged surgery. And it is not only costly, it is prolonged surgery lasting 4 to 5 hours. And the role is limited now with the advent of the ART procedure. And the only indication for present surgery is if it is a vasectomy patient reversal surgery people are doing. That also, because advent of the ART, more people are opting for going for an ART procedure. So azoospermia can be pre-testicular, testicular failure, or post-testicular, that is obstructive azoospermia. So in obstructive azoospermia, we can retrieve the sperm either from the epididymis or from the testis. So how do we retrieve the sperm in obstructive azoospermia or in azoospermia patients? Wait a minute, something happened. Okay, so obstructive azoospermia, as I told, we can retrieve the sperm from the epididymis, that is PISA, percutaneous epididymal sperm aspiration, or by the testicular sperm aspiration. And non-obstructive azoospermia, usually the testis will be small or soft, FSH will be high. And as the biopsy report, usually I told, if it is hyperspermatogenesis, if we get sperm, we can utilize that. And it is possible if we can retrieve the sperm and in non-obstructive azoospermia. So from the epididymis, this is a simple procedure, local anesthesia with sedation or without sedation or regional block can be done. It is done with a small 19-inch gauge needle attached to 10 ml syringe, or we can use even smaller needle with media. It's a simple OPD procedure, which is very inexpensive and effective procedure. And there is no need for incision or microsurgical experience for that. But the only thing we have to worry about, we have to be careful about a scrotal hematoma as a complication. Most of the times we can retrieve the sperm in obstructive azoospermia with normal FSH, normal size testis, if the epididymis is distended, and we can utilize that for an ICSI procedure. And in TISA procedure, that is testicular sperm aspiration, usually it is done by the local anesthesia or with sedation or regional block. We can use scalp, 18 gauge scalp vein with 20 ml syringe, and we give negative pressure and try to retrieve from the testis the seminiferous tubules and the fluid from there. We can retrieve. It also doesn't require any incision or microsurgical procedure experience. And in non-obstructive azoospermia, usually when the FSH is increased, so the size of the test, which is the most important thing for how much sperm we can retrieve, size and the testis and the consistency of the testis. Then comes the FSH level, and the chance of retrieving the sperm depends on that. And if you cannot retrieve the sperm by the testicular sperm aspiration, most of the time in non-obstructive azoospermia, we end up in going micro-TISA. What is micro-TISA is we open the testicular tissue and under the operating microscope, we identify the healthy speminiferous tubules and take this tubules and examine under microscope. It is done on the day of the ovum pickup, so that whatever sperm and we have to use it for ICSI procedure, or the day previously that sperms are incubated and we are used for ICSI. When we froze the micro-TISA samples, the chance of retrieving the sperm after on the thawing is very less. So it is ideally done on the day of pickup or the day just previous to the ovum pickup. So the goal of sperm retrieval in testicular failure is to obtain the sperm and with minimal damage to that, because if you too much damage like microtissa, that chance of fibrosis, chance of breaking the testicular blood barrier is there, so the future retrieval chance will be less. And it is told that we can do up to 3 times microtissa procedure, but each time the chance of fibrosis and chance of retrieval the sperm next attempt is less. And when we obtain the sperm, we can use that for ICSI procedure. The chance, if a good number like from the epididymis or from the normal tissa, not the microtissa, if we get good sperm, we can cryopreserve and use for ICSI procedure. ICSI is intracytoplasmic sperm insemination into the cytoplasm using the micromanipulator. And genetic, I think one talk, Dr. Veronica will be talking about that. But usual recommended is severe OAT or azoospermia. We have to do karyotyping to rule out any karyotyping defect or Y deletion. The importance is that in Y deletion is that if you do the AZFA, that is azoospermic factor A, the chance of retrieving sperm is less. But if it is C, we can retrieve the sperm in 70% of patients. And if it is ZF B or B plus C, sometimes we can get the sperm. So the chance of retrieving sperm as ZF A is 70%. More than that, we must counsel the same. Even if you get the sperm, the same Y chromosome can inherit to the male child. So the same sperm abnormality can be inherited to the male child. That is one other significance of doing the Y chromosome microdeletion patients with azoospermia and severe oligosteroteratospemia. So CFTR gene mutation is another thing which is associated with congenital bilateral absence of vas difference. So here we have to screen the partner also. If the partner is a carrier, the chance of inheritance is more. That subsequent talk it will be told. So if it is a male examination in semen analysis, if it is abnormal, we have to look for if it is azoospermia. Then you have to follow the what we are told. But if it is a oligostenospermia, we have to rule out in subsequent ways. So according to semen analysis, it can be oligospermia where the concentration is less, or severe if it is less than 3, or asteno if the motility is less than 50%, or teratol if the morphology is less, or oligosteroteratospermia where a defect in concentration, motility, and morphology are there. Aspermia if there is no ejaculate. Hemospermia if there is blood in ejaculate. Pyospermia if the white blood cells are more than 1 million per ml. And there are some studies where code the oligospermia as different, but usually normally told according to latest WHO criteria is more than 16 million per ml, and mild to severe varies with different if you do the different semen analysis, it may vary in individual, and usually it is associated with morphology and motility. That's why it is commonly told as oligosteroteratospermia. And there are, you must, if it is OAT, you must roll out the other lifestyle modifications. But whether if it is severe, we must roll out the chromosome and Y chromosome defects. We have to rule out. And most common is the Klinefelter's chromosomal defect. And also it is common in neoplasm like seminoma, and very rarely in severe varicocele we can get oligosteroteratospermia, but the chance of azoospermia caused by the varicocele is very, very, very rare, although some studies has been reported. And some drugs can also cause mumps, as I told you. If it is with arthritis, it can produce also rarely infection like prostatitis will produce oligosteroteratospermia. So if you look into the causes of male infertility, there are
Sorry to
incidents.
interrupt you, sir.
Yes, 2 minutes.
Okay, sir.
Depending upon the different studies, most of the studies tell different incidents, but varicocele is supposed to be most common in most of the studies. So when the patient comes, we must look for other local examinations. As I told us, testis size, whether it is epididymis, distended, vas, everything has to be seen. Along with that, we have to look for varicocele, hydrocele, and hernia. And hormonal evaluation in oligosteroteratospermia is indicated if the semen concentration is less than 10 million, if there is a rectal dysfunction, if it is hypospermia, that is semen volume is less than 1 ml, or signs of other endocrinopathies. And if it is a hypogonadotrophy, here also oligosteroteratospermia also it is an indication for medical management that and Dr. Kunjumoidin will be talking about. And if it is more than 8, it is compromised testicular function. So if it is oligospermia with high FSH, it is better to advise to go for IRT, assisted reproductive technique. And most of the time, although it is advised to rule out varicocele, clinical examination is the best. We can do the scrotal ultrasound and Doppler in doubtful cases, and transrectal ultrasound only if a dilated jaculated duct obstruction, which is very rare. And varicocele, best is the subinguinal microscopic surgery. And we have to always differentiate what is the cause, whether it testicular, post-testicular, or pre-testicular sexual problem in the cases with severe oligosteroteratospermia. So to conclude, azoospermia, when the patient comes, you must always differentiate whether it is obstructive or non-obstructive, or whether it is hypogonadotropic hypogonadism, and subsequently proceed as we discuss. Thank you for patient hearing.
Absolutely, Dr. FOGSI, very well said. And we really need to know about whether it is obstructive or non-obstructive, because that, especially before counseling. So I think we can start the third one.
Yes,
Third
yes,
session with,
Stacey, it was really very nice. It was a treat to listen to you as well, because you covered almost everything. And it's a great pleasure to have the next speaker. And Dr. Kedar Gandla will be joining us. Kedar has been the secretary of ISAR, as well as Maharashtra ISAR as well. He's the treasurer of Mumbai OG Society, and has been secretary of Mumbai Society as well, secretary general of ISAR previously, and over 25 national and international publications, more than 500 lectures and talks at national and international level, and has conducted over 100 IUI workshops. So we welcome Dr. Kedar Gandla, one of the very staff faculties here today. Welcome, Kedar, to this wonderful ICOG ISAR program. It is a treat again to have you on this podium. And again, we would all like to listen to you. Of course, myself, Dr. Nimish Shelat, formerly a very, very active member of ISAR, and also president of ISAR Gujarat chapter, a founder of ISAR as well, and organizing chair of AICOG 2027 at Surat. I welcome you all for that meeting. But at the same time, let us listen to Kedar Gandla here, please. Join us.
Thank you very much. I hope everybody can listen to me.
Yes, yes.
of course.
Yeah.
Dr. Kedar is going to talk about ovulation induction, which is, I think, the cornerstone of all fertility protocols, because the challenge lies in optimizing the outcome. So over to you, Kedar.
Thank you. So the topic is ovulation induction for IUI, and we go to the natural conception has very little chance, and as the
Can you make it slideshow, Kedar?
Okay. Yeah, sorry. Yeah. As the duration of
No, it's not slideshow, Kedar.
Yes,
Yeah,
yes.
now it is, yes.
Yeah. So the natural pregnancy rates falls down. So effectiveness of ovulation induction over IUI is far better than a natural cycle IUI. Natural cycle IUI one can attempt only in patients with, say, vaginism or erectile dysfunction or donor IUI. But for routine ovulation induction for PCOS, low AMH, I think ovulation induction is necessary. These are the indications of IUI, especially mild male factor, not the severe one. Grade 1, grade 2 endometriosis, we have to do an IUI. And relative indications are these, where you can try vaginal insemination first and then try the IUI. The treatment of IUI is shorter, less invasive, less expensive than the morbidity of IVF. And when you compare the invasiveness and expensiveness of IUI appears to be giving similar pregnancy over a period of time. So cost effectiveness of IUI is far better. When we are talking about success of IUI, one of the most important determinant is for number of follicles at the time of insemination. Now, in IUI patient, one should try and achieve 2 to 3 follicles only of 18 to 20 millimeter on the day of the trigger, and achieve pregnancy earliest, avoid multiple pregnancy and ovarian hyperstimulation. So rather than having a monofollicular genesis, to have multifollicular genesis will achieve the more ideal pregnancy. 1 to 3 pre-ovulatory follicle, triple line endometrium. The problem is if you don't get response or more response, good response with low endometrium or thin endometrium or inadequate ovulation could be a problem. So factor influencing control over hyperstimulation is age of the woman, BMI, and what is the cause. So if the patient has endometriosis stage 1, stage 2, where the ovarian reserve is less, then the patient will have lesser response. The patient comes to you either on day 2, 3, or 4, do ultrasound. If there is a cyst, do an E2. If E2 less than 60 means the ovarian cyst is non-active and you can proceed with stimulation. Assess always how do you decide the dose and type of protocol. If the patient has previous OHSS, if yes, with what dosage, what is the age of the patient, younger the patient, higher the risk of OHSS, AMH, AFC, higher the risk. If the type of ovary is PCO, again the risk of OHSS is higher. Always look at the previous history and any previous IUI failures. If patient has undergone 6 IUIs with a protocol, there is no point in doing the same protocol again in your clinic, thinking that it is going to cause a miracle. So, number of follicles 1 to 3, IUI between day 13 to 16, endometrium more than 7, ovulation induction corrects the subtle luteal phase defect. You can do with oral ovulation. The more important is the combined approach a gynecologist now should be starting rather than doing oral ovulation or only gonadotropin. So when you use letrozole, safe, effective option, first line of ovulation induction. If 2.5 doesn't respond, you go to 2.5 BD, no response, then you do step-up protocol or extended protocol, and that will cause ovulation. When you go for gonadotropin stimulation, why you need evaluation? Because the therapy is expensive with potential side effect of multiple pregnancy and hyperstimulation, and success is not 100%. Husband, always do a recently done semen analysis, as Schembecker pointed out, from a standardized laboratory. Old semen analysis, you do not start the report, endocrine abnormalities, and look at the endometrial assessment in a natural cycle. If the endometrium is good, then nothing to be worried. If the ET is less, then you do need to do hysteroscopy. Tubal evaluation, I generally look at laparoscopy as an approach to rule out peritoneal factor. So gonadotropin indication, if they fail CC or letrozole with highest dose for 5 days, if they had miscarriage after CC, patient's age is about 35, long-standing unexplained infertility, mild and moderate endometriosis, and mild male infertility will always help. In meta-analysis of control 22 studies shows higher pregnancy rate with gonadotropin than combined with clomiphene and IUI. Again, another study suggests that you can have a IUI with ovarian stimulation or gonadotropin with strict cancellation criteria. I will come to that little later, but always patient's opinion has to be taken before cancellation of cycle. The next thing is which drug to be used. There is no difference between FSH and HMG. How do you monitor? Day 2 ultrasound, and ultrasound. As the follicle about 12 millimeter will start growing 2 to 3 millimeter per day, according to that you should give the appointment. Hormonal assessment, E2 to be done only when the patient does not respond at all, to document that patient is not responded, or if there is more than 4 or more than 8 to 10 follicles on each side, to rule out a potential hyperstimulation or multiple pregnancy. Progesterone to be done on the day of the trigger if previous 3 IUIs fail, to know whether premature LS surge has happened or not. How do you calculate the dose of gonadotropin? Simple calculation, say patient's age is between 30 to 35. She's PCO type, you can start very safely with HMG. If she's poor responder, means the AMH is low, you can start as dose as high as 225. So optimization of gametes, always do optimization before doing the IUI. See, if you have an obese patient, ask her to do weight loss, give her insulin sensitizer for at least for 3 months. Or if the patient has got low AMH, poor responder, you need to give her antioxidant and make them responsible. The dosage will depend upon AMH, AFC, and BMI. A simple technique where the antral follicle count, which is practical approach, versus weight, will give you the idea of deciding the dose. Now, for example, antral follicle count of 15 and weight of the patient is 65, you can start the dose of 75 IU per day. So, if your threshold of gonadotropin is below the threshold, then there will be no recruitment. If you go too high, you will have more response. So best is to follow letrozole followed by HMG. So day 2 to day 6 you can give. Day 7 onwards you can start HMG, which gives you, according to this study, gives far better pregnancy rate, less number of HMG use, good endometrial thickness, and good implantation rate. With letrozole, which increases the follicular sensitivity to FSH, improves the endometrial thickness, decreases the requirement of gonadotropin, and safe, effective, mild hyperstimulation. So start HMG 75 IU, give it for 4 to 5 days, then do a scan. You will find monofolliculogenesis, means your threshold was correct, you produce single follicle, but you need 3 to 4 follicles. So next time you will have to increase the dose. If you get exaggerated response, we'll come to later. If there is no response, we'll go later. If exaggerated response has come, you do step down protocol. So you reduce the dose from say 150 to 100 or 75 and then add GnRH antagonist, because multiple follicle will cause LH surge. If it still continue to be there, then the best thing is to add GnRH antagonist and tell them to go for IVF with embryo freezing, or cancel the cycle and tell the patient not to have intercourse because they still has risk of multiple pregnancy because of natural LH surge. If there is no response, you increase the dosage. If you increase the dose by double, you may get exaggerated response, no response, or some monofolliculogenesis to manage as what we have discussed earlier. Step down protocol. So you start with a higher dose first, get recruitment of 3 to 4. When the size is about 10 millimeter, you step down slowly. This is a little difficult protocol for beginners. Step up protocol is better. You start with 75, 2 to 3 follicles have recruited. Step up the dose to 30 to 50% and continue the dose. You will get optimum response of 2 to 3 follicles by step up protocol. Poor response, one tends to increase the dose double, but increase the dose by 50%. Hence, multi-dose vials are useful. And after 3 to 4 days, monitor the patient again. In spite of slow and steady, sometime in time, you will get increased risk of hyperstimulation. Practical tip, you must use gonadotropin if you have a proper facility. Starter with softer stimulation like Letroz HMG, and do not use multiple protocols at the same time because you have to get familiar to one protocol. No matter how, remember, the response of the patient will differ from patient to patient and in same patient from cycle to cycle. So when do you cancel the cycle? No recruitment after 14 days of HMG, or if there are more than 4 follicles to prevent multiple pregnancy. Now this particular part is very important, that you have to counsel the patient that look, you have a risk of multiple pregnancy. Generally in our country, we do not talk about this. And hence today, when IVF consultants have come down to single embryo transfer, higher multiple pregnancy rates are formed in IUI cycle. Or if there is more than 4 or 5 follicles on each side and E2 is more than 3000, one has to cancel the cycle with the risk of ovarian hyperstimulation. So letrozole followed by gonadotropin or letroz followed by gonadotropin. The only disadvantage of the gonadotropin is the cost is high. intensive monitoring, frequent visit, LH search, OHSS, and multiple pregnancy. So slow and steady is better. Why do you need to give trigger? You need to do the timing of the IUI, and the LUF can be prevented. Natural pregnancy rate gives you 8%, letrozole will give you 11%, gonadotropin in unexplained infertility will give you 25%, combination will give you 21%. So one should know the risk of multiple pregnancy. Spontaneous is only 1%. IVF, it can go up to 20 to 30% if you do 2 embryo transfer, and in IUI it can go up to 10 to 15%. So what is the bigger issue? The average age of twin delivery is 35 weeks. 25% of that will require NICU admissions. Average stay will be 18 days. So they will spend more money in NICU than for your IUI. This is what you wanted. This is the most ugliest part of the IUI. Now, premature LH, just to touch upon, just before the trigger, if you do LH, if it's more than 10 international units, or progesterone more than 3.2 nanogram unit, means your LH surge is already happened, and you should not give the trigger, which happens in about 25 to 30% of the cycle. And typically, if your follicle is 20 millimeter, you have not done the progesterone, and you have given the SCG and done the IUI, patient has failed. This could be because of this premature LH surge causing increased progesterone, and the endometrium is moved forward as compared to the follicle, and hence the pregnancy will not happen. So the antagonist works by reducing the LH surge before the ovulation trigger, that prevents the progesternization of the endometrium, especially in gonadotropin cycle. Now, this paper in 2016 says delayed administration of GnRH antagonist when the size is more than 16 millimeter helps in preventing premature LH surge, but there is no improvement in pregnancy rate. Again, another paper in 2015, no significant improvement in pregnancy rate, but more number of follicles are found. But this meta-analysis, which shows addition of GnRH antagonists to improve the control over IVF stimulation, increases the clinical pregnancy rate and live birth rate. Now, the question is whether we can use oral GnRH antagonists for IUI. Majority of them will be tempted to do that, but let me guide you. The oral antagonist is found to be teratogenic, and hence I recommend that not to use oral GnRH antagonist for IUI for controlling LH surge. GnRH, the antagonist injections are far better. Thank you very much, FOGSI and ICOG, for giving me this opportunity to present my work.
Somebody was asking for why do we do dual trigger? So can you tell them, please?
The dual trigger, if you have LUF, then it helps in improving the quality of ovulation. That is one. And some papers are showing that the dual trigger gives better pregnancy rate, especially in IVF cycle, by improving the oocyte quality.
Kedar, please stop sharing.
Okay. 1 minute.
I think, I mean, as we are running short of time, the discussions, questions will be in the chat box, and please answer according. That is what the instruction. And thank you, chairpersons, especially Nimish Alet sir, Anju Soni madam, Ragna Agarwal madam, for coming this, and all the speakers, Dr. Chaitanya and Dr. Kedar for coming. And Kedar agreed to talk in between his vacation. He was kind enough to agree and come and talk here. Thank you. I think all the listeners, if you have any doubt, you can we can discuss in the chat box so that we won't get delayed. with this, we will go ahead for the second session. I think Dr. Ankita, please introduce the chairpersons. Kedar, can you please stop sharing?
So proceed to our second session for the day. I invite the chairpersons for the session. Dr. Leela Vyas, ma'am. She's Professor and Head OBGYN, Gitanjali Institute of Medical Science, Jaipur, and Senior Consultant Aesthetic and Cosmetic Gynecology, Jaipur. And she has many organizational positions to her name. Ma'am will be joining us in some time. The second chairperson is Dr. Mala Srivastav. She's Senior Consultant and Professor Gripma at Sir Gangaram Hospital, New Delhi. She is past AOGD President and awardee of APJ Abdul Kalam, among the other awards. Welcome. I request the chairpersons to kindly introduce the speakers for session 2.
Before going to chairperson, remind you, those who are joined late, since this is a certificate course, all they have to join for all the 3 days. And all the 3 days, there will be post-test, no pre-test at the end of the last panel. After the last session, there will be post-test, and you have to answer that and get at least 50%. Then ICOG will be giving the certificate, which will be sent within one month. Over to you, the chairpersons.
Thanks, Dr. FOGSI, for making me a part of this illustrious course. It's my pleasure and privilege to be a part of this ICOG certificate course. It's my pleasure to introduce our first speaker of this session, Dr. Krishna Mantravadi. He is the Scientific Director, Oasis Center of Reproductive Medicine, Hyderabad. He has done Masters of Clinical Embryology from Monash University, from where he also did the postgraduate diploma in reproductive sciences. He's an MBBS from Rajiv Gandhi University, Bangalore. At Oasis, his main area of interest are cryobiology, in vitro maturation of oocytes, andrology, and men's health. Currently, he's working on employing newer techniques to improve the success rate of IVF in PCOD and recurrent IVF failures. Over to you, Dr. Krishna, and you're going to speak about semen preparation techniques for IUI. Over to you.
Thank you so much for the kind introduction. Well, I think we'll keep it informal. If there are any questions, I'll be very happy to interact with you all. So without further ado, let's just move on to this. So be it IUI or anything, there's a thumb rule in assisted reproduction, and that is we should be as close as possible to the nature. We do not want too many interventions which might affect the outcome. That's not to be done. So we always have to keep that in mind. And whenever there's any newer technology intervention, I think we need to go a little slow. So today, let's just look at this very basic aspect of semen processing. So, straight to question to the answer. Why do you want to prepare the semen? It's because you would want to get a good proportion of total motile sperm concentration, because you want to enhance the chance of pregnancy. And then, of course, you would want to remove certain aspects of the seminal plasma because they could have detriment levels. So we want good quality sperms so that we could inseminate the uterus. So overview, yes, I know it's all about collecting a fresh semen sample. You assess for the quality on that day, because you could have a assessment done before, but on the day, for various reasons, the ejaculate could change. It's always good to do an assessment. Then you're going to prepare the semen and then be inseminating it. So that's a rough overview. So what ideally every semen preparation method, because there are at least 3-4 of them which are normally and commonly used in our routine clinical practice. But whichever method we go, it should be quick, easy, cost-effective, and it should give me the best separation. But at the same time, there shouldn't be any kind of a damage to the sperm. We've got to keep these basic thumb rules in our mind. So swim up, double density method. I think two very commonly used methods. We'll spend quite some time getting an overview with these two methods, and I'll briefly touch upon few newer recent advances that people have experimented in the field of assisted reproduction. So swim up, it's as the whole terminology says, it's just coming up. So it's a migration-based technique. So you could do it directly or indirectly, as you could see in this illustration here. So if I'm saying it's indirect swim up, what ideally are we trying to do here is we're going to mix the sample. Well, we're going to dilute it with some sperm preparation media, which is basically a HEPAs or a MOPS-based buffer solution. Then we're going to centrifuge it. So you've kindly mixed your seminal plasma with the media, you centrifuge it. You then remove the supernatant, and then you overlay with some fresh media, and you're letting the sperm get into this fresh media. You wait for like 30 to 45 minutes where all the motile sperms have swimmed up into your fresh media, and that's inseminated.
Rinky.
That's one thing. Or you could do a direct thing where you first put culture media and then you do an underlay of the sperm, and then you're letting the sperm come up. So, advantage, it is simple, easy, cost effective. There's minimal manipulation here. The amount of centrifugation that you do in a swim up is least. And if you really look, this is what is WHO recommended method. We always think, because you go to any fertility center, people are using the next technique, what I'll discuss, which is the double density preparation technique. But if you really read the WHO manual, so I'm sure you all are aware, I think WHO has the semen analysis manual. The last is the 6th edition, which has come in the year 2020. If you really refer to that WHO manual, it says the swim method is the preferred method because there's minimal manipulation and deviation from the normal process. But what are the disadvantages of the swim up method? I think it's not very efficient because there's a little risk of contamination. You might not be able to get the best extraction. We keep underlining that bit. We want the best fraction of motile cells. That's what a semen preparation method should ideally aim at. And a swim up might not give you that best recovery rates, but the advantage is there's minimal centrifugation that you do. Let's all of us be very clear that, in serodiscordant high risk couples where the female partner is negative for the viral infection and the male partner has it. So the natural intercourse does put across a certain amount of risk, retroviral infections or the hepatitis infections. So in such situations, doing a swim up is not recommended, and a double density method would be the choice of method what we would want to take. And this whole swim up is going to take 35, 45 minutes to 1 hour. It's slightly an extended process that we do. So next is double density gradient. So these are basically media with some silica suspended particles. So nowadays we don't make medias anymore. Everything is commercially available. So ideally what you're doing, I'll take you to this picture here. If you look at, there are different layers of density. So there's an 80% density, 20% density. Over that you do a sperm overlay. So ideally, these are more like the filters. So what they do, the principle here is weight by volume or density of the sperm. So a sperm with a normal morphology is considered to be more dense, and that is the one that will go to the bottom of your test tube when you're doing this centrifugation process. So double density, it's a filtration method. And if you can again refer back to that pink little image at the right-hand corner, you see this non-motile and the dead sperms are trapped. The yellow layer is trapped in between the two blue layers, and only the motile fraction is coming down. So ideally, it's a filtration type of method, and it gives you a good proportion of motile cells. So the advantages is, you're going to get a better proportion of count, motility, and morphology here. It's relatively fast and easy to a swim up technique, what you've done. The recovery is better and it's more standardized than any high risk patient. Even in severe oligozoospermic patients, I think the preferred choice is double density method, because it's going to do a nice filtration and give you only the motile cells. In fact, if you off late, if you see testicular semen sample preparations also, we prefer doing a double density method of preparation, because it's going to remove your debris, dead cells in a very efficient way. You get a very cleaner preparation. Well, what are the disadvantages? You're rotating the sperm at close to 1000 or 1200 RPMs, or we say G, which is the gravity is what they call. So 300 to 600 G is ideally the force, the speed at which the centrifuge should be running, and around 10 to 12 minutes. So just rotating at a very higher speed, the sperm cells itself might generate reactive oxygen species, and there could be further damage of your DNA of the sperm. It is adding on to the cost, and it is a skilled procedure. This whole thing of layering the density, I think that is where the skill is needed, because you got to do it very gradually. Otherwise, these densities are going to mix amongst themselves, and then the whole filtration potential is gone. So you've got to be keeping that in mind. So it's slightly skilled, but it's not rocket science. So that's about the swim up and the double density method. Swim up is what WHO recommends. Double density is what most commonly practiced, and it gives you the best recovery. So ideally, people have been doing a lot of RCTs. There's meta-analysis to see whether it is swim up or double density, which gives you the best. I don't really think there's a winner there. But I think pregnancy rates with an IUI are, on an average, based on the prognosis of the patient, somewhere from 10% to 20 or 30%. But I don't think you could predict to your patient the success of an IUI beyond 30%. So in that bracket of 10-30%, I don't think swim up or density was able to further enhance the success. And this is where, especially when we were wanting to do IUI, people wanted to look at some advancements which could further enhance the recovery of sperm, recovery of best quality sperm, so that you could get the best pregnancy outcomes. And that's where this next newer technique, which is MAX, or magnetic activated cell sorting technique, was introduced. So to keep it simple, what was done in this particular MAX technique? Ideally, this works on the principle of the lipid peroxidation of the sperm's cell membrane. If there's oxidative stress, then there's a higher proportion of lipid peroxidation. So they put these annexin beads, and then this blue thing, what you see here is a magnetic field there. So the sperms which are fragmented or having a DNA damage will actually combine with the annexin beads and will get separated. The ones which have a normal DNA are the blue sperms, which will pass through the magnetic column, and then you could go ahead and do this. So I think there was a lot of buzz around this newer technique. They said this would give you the best prep. But again, after 5 or 6 years of this being in practice, I think it's very controversial. We don't know if it's helping, and it is an expensive intervention. It will cost you almost 7 or 8,000 to do one max semen preparation. So this technique didn't really become famous. Advantage, yes, it's separating sperms with good DNA. The disadvantage is the cost, availability, and evidence not being in support. The next is microfluidic, which is now everybody is after this very new technique. This is very, very physiological. No centrifugation needed. It is so simple. You just add 150 microliter of semen preparation media, 850 microliters of semen. You wait for 30 minutes. It basically works on the principle of microfluidics channels. Sperms with a good morphology and motility will get channelized into a particular direction, and you just take them and you inseminate it. So it is easy, not very skillful. There are studies which say that it gives the best quality sperm, but again, probably it's been in practice for the last 4 or 5 years. There's only been 2 RCTs on use of microfluidics in the field of assisted reproduction, and absolutely no meta-analysis or a network meta-analysis that's been done so far. There's not much evidence supporting its role to enhance success of the semen preparation technique and this ART cycles. So to keep it short, I think semen preparation is needed because you have to remove the seminal plasma. You want a good proportion of total motile sperm concentration. So this is very important. After you've done the filtration, the final pellet what you get should at least have 5 or 10 million total motile sperm concentration. We don't want those dead cells, morphologically abnormal ones. A nice progressively motile concentration of at least 5 to 10 millions. That gives you a plateau of that somewhere between 10 to 30% of your IUI success. And if your TMSE is less than 5 millions, I don't think, from a male perspective, your success is going to be great. Swimmer port double density, I think these are the commonly used, and that's what we're doing. Newer methods, max microfluidics, still need further evaluation. But so while you're doing, I think, put in a lot of thought, ensure that semen is prepared. Older times there used to be this whole thing that, oh, you don't really have to prepare the semen. Just take a semen into the pipette and put it around the cervix. What we don't want is the seminal plasma to get into the uterine cavity, because semen has prostaglandin and it will bring about uterine contractions. Semen is not a sterile body fluid. There could be a lot of WBCs and downsides, and this gets into the uterine cavity. There's a risk of endometritis, and the lady has lost her whole reproductive potential. So a cleaner, sterile semen preparation is an essential aspect of your IUI to give you the best success. Thank you so much for this opportunity.
Hello. I think that was a real exhaustive and extensive scientific deliberation from Dr. Krishna, who had vividly described the different types of semen preparation techniques for IUI. I request Dr. Leela Madam to introduce the second speaker of the evening. Over to you, Dr. Leela Madam.
At the outset, I convey my sincere thanks to whole team ICOG and FOGSI, that Dr. Sunita, then Dr. Parag, and all Dr. FOGSI, especially thanks to you. You called me that, and all nice to see that Dr. Mala and you. And it's my opportunity to introduce Dr. Kunjumoidi, and definitely we just, I think in Dr. Kunjumoidi, we met in our managing committee meeting recently. So in credential, he is a gold medalist in MD and is having this advanced training in laparoscopy from the France and training in the ART from the Singapore, and working as a chief consultant at Maulana IVF centers for the 21 years and chief consultant at MRC IVF Kozhikode since 2009. And he is chairman of ARMC Aegis Hospital, and he is basically he's a good academician as far as I have heard so many times him, and he is the master of the subjects, and his area of interest is ART and laparoscopy, and he is presently that joint secretary of Indian Fertility Society and president in this Parinthama Ops and Gynae Society. So now, Dr. Kunjumadi, you have to, that I think he will do the justice with that topic. The treatment of male infertility, we all know it's a very difficult to treat, but he will make the subject in a very simple way and go proceed for the practically how to proceed. So all our students will get benefited by that. Thank you.
Yeah, thank you for the nice introduction, even though the CV was maybe a decade old. So currently, I'm the past president of Kerala Federation of ONG, and currently the medical director of Birla Fertility ARMC Kerala, and working at Calicut and Perinthilmana, and I do practice in Dubai and Doha and Muscat. So with this few words, I would like to go to the topic that is given to me, and I express my sincere thanks to FOGSI and his team for giving me this opportunity. And the topic is nothing but medical management of male infertility. So it is something, the male infertility being treated medically, that is one of the things which is being exploited in a large canvas by a lot of pharmaceutical preparations, and which are being trusted onto the practitioners. And we all come across a lot of preparations, a lot of combinations even though many of these combinations are not even considered as drug, most of these combinations are the food supplements. So we all go behind that, and most of the patients coming to us might have received the tons and tons of these drugs. So what does it mean, the medical management? It can be empirical treatment of idiopathic oligospermia. Idiopathic means it will be normogonotropic. We won't be recognizing any specific reason for that. And specifically the hormonal treatment of hypo and aromatase inhibitors in obesity-related male infertility, where obesity is associated with oligospermia, and specific treatments for male accessory gland infections, and antioxidants for oxidative stress alleviation. So this is the point which I was mentioning about a lot of preparations available in the market, and many of the things do not have the evidence to support it. So what are the empirical treatments for idiopathic oligospermia? It can be the aromatase inhibitors like letrozole. It can be androgens, then hormones like HMG, FSH, and HCGs, antiestrogens, bromocriptine, alpha blockers, and steroids. So generally, most of these things empirically are not effective. That is the reality. In spite of giving as empirical thing, we know very often, whether it is empirical treatment given following the embryo transfer, recurrent implantation failure, recurrent pregnancy loss, in most of the situations, it is just giving for our satisfaction, not even for patient satisfaction. So injectable testosterone, that is testosterone per se, that can be harmful. Why is it so? It can affect the gonadotropin releasing hormone. It can inhibit it. So that can result in less FSH and LH. So ultimately, the biggest danger will happen, that is the decreased intratesticular testosterone. So this will ultimately hamper the spermatogenesis for a long period of time. And ultimately, it can end up in azoospermias. So who will benefit from medical treatment? So this here we have 4 towers. One is total testosterone level, FSH, LH level, estradiol level. So accordingly, we categorize this thing into various categories. So if the total testosterone level is less than 300, then you have 2 situations. One is normal or elevated FSH and LH. If it is less than 300, normal or elevated gonadotropins, or it can be hypo, that is less than 1.2 FSH and LH, it straight away, it goes to the hypo. Then we have the estradiol levels. With that, you calculate testosterone estradiol ratio. It can be either less than 10 or more than 10. So if it is less than 10, that is considered as aromatase hyperactivity. So you give the aromatase inhibitors. So if it is more than 10, so the prognosis is not very good. So coming to a few things about male hypogonadotropic hypogonadism. So that will ultimately result in deficient virilization at puberty, hypertrophic testes, testicular volume will be lesser and soft. Semen analysis will show no sperms. FSH and LH will be low. Basically, it will be less than 1, and low testosterone concentration, that is less than 300. So it can be congenital, that is Kallmann syndrome and Prader-Willi, or it can be acquired, that is pituitary tumor, testosterone therapy, and steroid abuse. That is the one thing which has been said to be very common. And this steroid abuse need not necessarily be the abuse of steroids in the gymnasiums and all the bodybuilding and so on. This steroid abuse can come along with a lot of drug addicts and a lot of the latest types of chemical drugs, addictive drugs, that can ultimately result in low testosterone level inside the testis. So adult onset hypo, classic treatment for male hypogonadism and infertility is urinary HCG, 1000 to 2000 intra-unit, intramuscular or subcutaneous, twice or thrice per week, and that has to be continued minimum for 12 weeks. And recombinant HCG means it has to be 4 times per week. So I repeat, urinary HCG 1000 to 2000 units, intramuscular or subcutaneous, whatever it is, twice or thrice per week. And the highlight is it has to be continued for 12 weeks consecutively. Then adult onset hypo, again, the series of men with adult onset hypo, the recombinant HCG that can be given, and that has been, there are a lot of studies by Sandro Esteves, and that has shown a considerable improvement in the intratesticular testosterone level and the hair distribution and spermatogenesis, everything. And these are the principles of treatment. Gontrapin 3 to 6 months of treatment is usually required to induce spermatogenesis. That is very important. We should not leave the treatment, or we have to counsel the patient initially that it will take long time, and you have to give that sufficient duration of time to have the spermatogenesis set in. Then HCG is sufficient to initiate spermatogenesis, but FSH is required to complete the spermatogenesis, particularly in patients with the congenital abnormalities. And again, initiation and maintenance of spermatogenesis, that is 2,500 to 3,000 units IM every alternate day, along with HMG or FSH 75 to 150 units every alternate day. And pulsated GnRH therapy successful in men without cryptorchidism and inhibin level over 60, which I do not have personal experience. And median time for appearance of sperm 7.1 month and pregnancy 28.2 month. So it is, you just forget about this one, but the highlight is that sufficient number of weeks has to be given, and any changes will start only after 12 weeks, and you have a desirable effect only after 6 months. And monitoring FSH, LH, testosterone, and semen analysis 3 months after the treatment. There is no point in looking before that. Don't do some analysis before 3 months, nothing will happen. It will, if at all, it will start having some changes after 3 months. And testicular size may increase after 6 to 7 months of treatment. And semen analysis by the end of 12 weeks of treatment. All the pregnancies have been documented after 8 weeks of treatment. At least 3 months of treatment to see any significant change in semen parameters, and the treatment may last for again 7 to 8 months. Reversible anabolic steroid-induced hypogonadism. That is the one currently I have, as I mentioned, in the gymnastics and all. They used to give all these anabolic steroids for bodybuilding, muscle building, muscle strengthening, and all. The quality of sperm tends to normalize spontaneously. Quality of sperm tends to normalize spontaneously within 4 to 12 months after cessation of anabolic steroid abuse. And negative effect on sperm quality may persist for a long period of time. Simply stopping the use of anabolic steroids may lead to the resumption of fertility in certain proportion of male, and induction of spermatogenesis with gonadotropin analogs may be required in most of the situations. And use of reversible anabolic steroid, again, there is a role for the use of HCG alone or in combination with HMG as reported as an effective treatment for this group of patients to reverse the damage. And the restoration of fertility has been reported even in situations of persistent azoospermia up to 5 years after the anabolic steroid stop. Tell you that they have taken anabolic steroid, they all just tell, I have taken whey protein, I have taken the protein in this format, that thing. Ultimately, all this will contain most of these anabolic steroids. And you can imagine, just without having all these things, they cannot have this 6 to 12 packs and all. So generally, all these things will contain this at least a minimal amount of anabolic steroids. Then only these gymnastic firms, they will have the desirable result for their client. Large dose of anabolic steroids in the long term can lead to the development of withdrawal symptoms. What are these withdrawal symptoms? It can be mood disorders like suicidal tendencies, depression, insomnia, anorexia, decreased libido, fatigue, headache, muscle and joint pain, and the desire to take more steroids. And drugs that are targeted to relieve these symptoms include antidepressants, non-steroidal, anti-inflammatory, and clonidine. So don't ever think that 6 packs are not an indication that they can produce a baby, they can have fruitful sexual life. It can be the reverse order. So obesity and male infertility, it has a very pivotal role. And you see, insulin leptin, this leptin resistance, that is a major component in causing the insulin resistance, as well as resulting in the decreased intratesticular testosterone level. Ultimately, it leads to lot of initiation of lot of negative pathways, and the peripheral obesity that can lead to the release of the chemical estrogens. And estradiol levels and aromatase polymorphism. Aromatase is a product of CYP19 gene, and most common polymorphism is tetranucleotide repeat TTTAN, and higher TTTAN repeat is associated with increased estrogen level. And you can very well see in the right side graph the change in estradiol levels after weight loss in men with higher and lower number of TTANs and repeat 7 to 7 of the aromatase polymorphism. And oligospermia in men, there is a meta-analysis of 21 studies where 13,000, more than 13,000 men were evaluated with the risk of oligospermia. The overweight, BMI greater than or equal to 25, odds ratio is 1.28, 95% confidentiality interval, and obesity, BMI greater than or equal to 30, you can see the odds ratio is gone up to 2.04. The aromatase inhibitors again in obesity and associated with the odds. So what happened when the letrozole is applied? So there will be aromatase hyperactivity will be arrested. So basically total testosterone and estradiol levels, that is testosterone estradiol ratio of more than 10. And when there is hyperactivity, it will be less than 10. And letrozole, that will be very much effective in these patients. And it has to be given for a duration of at least 3 months. Then only will you have the desired effect. Then only you will have the desired effect. And not only that, see, obesity has the people just think that even though there is obesity, they can bypass it with a lot of medicines. The impact of obesity can be bypassed with medicines. No, it is absolutely wrong. The obesity has to be controlled. They have to do regular exercise, dieting, that the BMI has to come down. Along with this aromatase inhibitors, that will help. So there is a study of anastrozole 1 milligram QID for 3 to 6 months in oligospermia that has shown the increase in the ejaculate volume as well as the sperm count post-treatment. That is wonderful observation. And pure hypogonadism, severe odds and non-obstructive azoospermia are candidates for the ART candidates, and the medical options are the anti-estrogens and HCG or urinary or recombinant. Before sperm recovery in Klinefelter syndrome. Klinefelter syndrome is something where the sperm recovery is a very, very remote possibility, even though it is said to be possible in few patients. 68 men, this is a study again by Ramasamy et al. In Journal of Urology. 68 men with the non-mosaic Klinefelter syndrome, non-obstructive azoospermia and hypogonadism, they are the candidate for ART. Medication to boost testosterone production, aromatase inhibitor, and estrogens for 2 to 3 months, and micro-TCA as the sperm recovery method, and positive response, increase in testosterone of more than 100 nanogram per deciliter from the baseline levels. Though in such patients, the sperm recovery rate, sperm retrieval rate has improved quite a lot, statistically significant. And case series, unselected group of men with testicular failure and low testosterone level, micro-TCA again, medication to boost, again aromatase inhibitor, and positive response post-treatment, and again it is significant. So anti-estrogens in non-obstructive azoospermia. So basically the commonest anti-estrogen what we
Sorry
use
to interrupt you, sir. Sir, your time is up.
So I'll just rush it up in 2 minutes. So anti-estrogens are another options, and infections and male infertility. The treatment of male accessory gland infection is something you have to take care, mainly the prostatic infection. And here again, the spermatological outcome of acute epididymoorchitis post-treatment is better. And these are the infections you can see in the leukocytospermia. And multivitamins, again, that can be seen used to multivitamins and antioxidants. These are some of the things which we generally give for the patients. But coenzyme Q is something which has been found to be effective if give for proper duration. And to conclude, the empirical medicines for idiopathic odds, not recommended. Infertile males with hypogonadism are the candidates for medication. HCG is the treatment choice for adult onset hypo. And is indicated for obese. Aromatase inhibitor is indicated for obese men with odds. HCG or androstenedione in selected patients of azoospermia prior to sperm recovery, and minimum to trial duration of 8 to 12 weeks. Thank you. Thank you for the patient hearing. Thank you.
Thanks, Dr. Kunjumardin. You had really exhaustively told us about the medical management of male infertility, which is a very controversial and difficult topic in the practice. Thanks for your excellent lecture.
Thank you.
It's my pleasure to introduce our third speaker of the evening, none other than Dr. Veronica Arora. She's a consultant clinical genetics at Sir Gangaram Hospital. She was got a gold medal in DNB Super Specialty Clinical Genetics. She's a secretary, Delhi chapter, Anbai, head North Zone ISPAT Advisory Board of Myositis Society of India. Many accomplished features she had, lots of publication, lots of activity. Over to you, Dr. Veronica, for your scientific deliberation on genetics in male infertility.
Veronica, you can start sharing also.
Yes, good evening everyone. I'm just going to start sharing. Are my slides visible?
Yes.
Thank you, ma'am, for the kind introduction, and thank you, ICOG, for the opportunity to talk to this.
Veronica, your voice is low. Can you speak a little louder?
Yes. Is it okay? Better now?
Better.
Better now. Yeah.
Better. Okay, but okay, I'll just try to be close to the laptop and speak. So I'd be talking about genetics of infertility, a little bit different topic for the IVF specialists and maybe the residents present here as well. So we will discuss about genetics first and a little bit about the genetic tests before we dive into the male infertility part. So I've been asked to just deal with the male infertility part, so I'll stick to that. So when we talk about the genomic material that all of us possess, in each cells we have a chromosomal component that is present, and each of us have millions of chromosomes, obviously, and each cell contains 23 pairs of chromosomes. So a chromosome is divided into different parts, and there is a specific group of tests that tests for looking at abnormality of the chromosomes. On the chromosomes, then we have these DNA-like structures on which are placed genes. So we have two groups of genetic tests which we all need to remember. The first groups are the cytogenetic tests to look at the chromosomes, and the second group constitutes the molecular genetic test, which looks at the genes of interest for a particular disorder. So whenever we think of genetic tests, we think in terms of test for chromosomes and test for genes. So now the test for chromosomes can be divided into three, that is the karyotyping, the MLPA, and the FISH. Of course, there is another test which is a higher version of karyotype known as the chromosomal microarray. So let's talk first about the karyotype, an extremely important test and still not redundant from clinical practice. Karyotype was the first test introduced for chromosomal disorder. It is the naked eye examination of chromosomes under a microscope. So we see that all the chromosomes are present when we look inside the microscope, and we look at big deletions or duplications in the chromosomes. Because this test is done by a human being who is looking inside the microscope, the sensitivity to pick up small deletions, small duplications is not high. So a karyotype is, as we see here, is a graphical representation of all the chromosomes that are contained inside the human in their descending order of size. So each chromosome number 1 to 22 would have a pair. That is, one comes from the mother and one from the father. So if there are all present like this, it is known as a euploid structure. The second test that is shown here is also a part of the chromosomal tests. Here we have the Y chromosomes, the important chromosome for the male factor infertility and the male factor fertility. So in the Y chromosomes, as we can see, there are different parts. There is a small arm of the Y chromosome and the long arm of the Y chromosome. And the long arm is divided into the azoospermia factors, and that is factor A, B, and C. So we need to look that if one of these factors are deleted in presence of a male factor infertility, and these deletions can be detected by a test for chromosomes again, that is the MLPA test. Now we spoke about the test for the chromosomes, and now we speak about the test for the genes. Test for the genes is known as exome sequencing. Exomes are the areas of the genome that code for a particular protein and only constitute up to 1 to 2% of the whole genome. Rest of the areas do not code for any protein. So the test of choice to do if we want to look at the areas of interest in a gene, that is the protein coding area, is known as exome sequencing, which is the targeted sequencing of nearly every protein coding region, and this may be helpful in detecting genetic disorders when the karyotype and MLP and microarray are normal. So a gene consists of exons and introns. When we look at all the exons, which are the protein coding areas, this is known as an exome sequencing. So exome sequencing can be of three types. Targeted sequencing will only look at the disorders we are targeting. Whole exome sequencing look at all genes together, and a whole genome sequencing looks at protein as well as non-protein coding sequences. So the best test to do when you're looking at infertility in a male, you should do a whole exome sequencing if you're suspecting a disorder which is running in the family. So when do we want to test a male with infertility, thinking of a genetic cause? Do we always do it? So we do not always do a genetic test. So the indications include a non-obstructive azoospermia, severe oligospermia, and a non-palpable VESA. If we have one of these three, we go ahead and perform a genetic test. The utility remains that there is a better personalized treatment, there is an improved risk assessment for transmission to the offspring, a better counseling for potential health risk in infertile men. For azoospermic men, prior to testicular biopsy, finding a genetic diagnosis may help in predicting the chances of a successful testicular sperm extraction, which is incredibly an invasive procedure. Then, of course, in a cascade counseling means looking for similar genetic disorders in the family members and knowing already that and predicting that a future offspring may be suffering from an infertility disorder or a syndrome related to the same. So, approximately 4% of all infertile men are now diagnosed with a genetic cause. So, we have a percentage that is assigned to it, and this can help us to tell the patients for looking for a cause. But a majority, 60 to 70% of these remain without a clear diagnosis and are classified as idiopathic or unexplained. This is, of course, because of a lack of awareness for genetic testing and a lack of a newer testing modality which can look at these. So the main factors for male infertility include a hypothalamic pituitary axis dysfunction, the quantitative spermatogenic defects, the qualitative spermatogenic defects, and ductal obstruction or dysfunction. Genetic testing, of course, as I mentioned, is not indicated for all fertile men, but we should not do a genetic testing when there is a proven previous fertility, a known prior gonadotoxic exposure, examination highly suspicious for ejaculatory duct dysfunction, do not warrant a full genetic workup. So we can omit the genetic testing in these. The basic recommendation go like this, and there are for the European, the American Society, and the ASRM guidelines I have mentioned. So we need to do karyotyping, Y chromosomal deletions, and testing for cystic fibrosis in these following indications. You do a karyotyping when there is a non-obstructive azoospermia with the sperm or a sperm count of less than 5 million per ml, a severe oligo or a non-obstructive azo. You do a karyotyping. You do a Y chromosome microdeletion in the same indication when there is a non-obstructive azoospermia or the sperm count is less than 5 million per ml. And you do a cystic fibrosis testing, that is when you are thinking of CBAVD when the vasa are non-palpable. In cases when we are expecting a cystic fibrosis, the female partners should also be tested. So the CBAVD is the congenital absence of vas deferens, and this is present in the condition known as cystic fibrosis, in which there, in a severe form, there can also be recurrent infections, pancreatic insufficiency, and male infertility. So we think of CABVD in men with severe oligospermia or azoospermia and a low volume of ejaculated serum with this specific chemical profile, which mentions a low pH, elevated citric acid concentration, but what is most important is the presence of an absent or a low fructose in the semen, which indicates that there is no the obstruction component. So evidence of abnormalities of seminal vesicles of vas deferens on rectal ultrasound examination. So the CBAVD can affect one or both vas deferens. Bilateral absent occurs in 2 to 10% of all infertile men, but accounts for up to 40% of obstructive azoospermia cases. So a low fructose count again is indicating an obstructive component, and that should indicate us to look for a genetic cause of cystic fibrosis. Over 90% of men with CBAVD additionally have morphologically abnormal seminal vesicles. That is, in spite of the obstruction, there is an absence, atrophic or hypertrophic or even cystic vesicles. Physiologically, this results in abnormal semen parameters, as I just mentioned. Most commonly, the congenital absence of vas is associated with cystic fibrosis and is caused by the mutation in the cystic fibrosis genes. The diagnosis of CBAVD in a male with the following features: azoospermia and absence of vas on palpation, and also absence of the cystic fibrosis mutation. It is an autosomal recessive condition, and the offspring of this person is likely to have a full blown cystic fibrosis only if the wife is also carrying a mutation for the same. So when you diagnose a male with cystic fibrosis, you treat the obstructive component and they have a baby, it is also extremely important to test the spouse so that their offspring does not have a full blown cystic fibrosis disorder. Men with CBAVD typically have normal spermatogenic potential because it's only an obstructive condition and therefore are excellent candidates for ART. They should instead undergo a renal imaging due to high incidence of non-CFTR associated ipsilateral renal agenesis as well. Partners of men should additionally be screened for mutations in the CFTR gene to prevent a child with cystic fibrosis be born to such an individual. So an important point to remember. So in addition to cystic fibrosis, there is now another gene which is an X-linked gene known as ADGRG2, which has also been found to cause CBAVD. So we just don't look at CFTR, but now we have another gene, and I'm sure in future we will have more genes which will be causing male infertility. So the best would be to undergo a panel of genes, that is the exome sequencing, if we are thinking of CBAVD instead of just restricting ourselves to CFTR. The Y chromosomal defects, as I mentioned, the AZFA, B, and C, they can be deleted, and because the small parts are deleted, they are known as microdeletion. What to test and who to test? So we test because 75% of oligo and azoospermic men are suffering from this. Non-azoospermic or civil oligospermia, we find 10 to 15% of microdeletions. Due to relative high frequency of YCMD in oligo and azoospermic men, the society says that we need to test for the same. The test of choice is the MLPA. MLPA stands for multiple ligand probe amplification, and this looks at the different microdeletions, that is the AZF A, B, and C. And there is an implication of knowing these results and counseling the patients, because there are some men with AZFC deletion who have fathered son with ICSI, but they have to remember that if they have sons, that all of them will also have the AZFC microdeletions, because it is present on the Y chromosome. So another common syndrome before I end to be discussed is Klinefelter, without which the discussion of male infertility remains incomplete. Proceed. In men with Klinefelter syndrome, we have tall men who would be infertile, who would have mild intellectual disability, who will have gynecomastia, osteoporosis, and you will do a simple karyotype and you will find an extra X chromosome, as you can see here. So XXY will be a man with a Klinefelter syndrome. So this is the most common cause of sex chromosomal aneuploidy in males and females combined, and should be thought of in all of these situations. If you want a quick results for genetic chromosomal disorder, FISH is your test. Even for a Klinefelter, you order a FISH test, you get a result in 2 days, a more targeted and specific test for the same. The final groups of tests, if we are strongly suspecting a genetic cause, there are multiple family members or multiple generations having this male infertility, then we can look at other causes of male infertility. And I have just posted a 2020 review here, which is a great review, which shows that there are more than 100 genes now implicated at every level, at the level of brain, at the level of adrenal, at the level of testes and sperms, and all these can be tested together in the exome sequencing test. And such information helps end the diagnostic odyssey, helps really decrease the guilt of families and tell them what the cause is, and definitely help them in management of the same. Different genetics of different architectures and
Sorry to interrupt you, ma'am, but your time is up.
Yeah, I'm just concluding. So different morphologies of sperms have been associated with different genes. This is just one chart, maybe for residents who are interested can remember that different morphologies, different shapes are related to different genes, so we can really know which gene is affected with that. So finally, the take-home messages are that we can delve into the depth of testing, and we have to know that which type of defect is present in the sperms to decide the type of genetic testing which is to be done. A family history is to be sought in all cases. It gives us a clue about the type and the inheritance patterns to help testing. It also aids in definitive diagnosis and management. Definitely, there is no one single test for all patients with male infertility, and it has to be personalized depending on the phenotype of the person and the semen analysis reports. With that, I'd like to conclude my presentation. Thank you.
Thanks, Dr. Veronica. Dr. Leela Madam wants to say something.
Yeah, Veronica, it's very nicely presented. Actually, just genetics of male infertility part is very important, because to treat them is again an important thing, but still the diagnosing them and to counsel them. If any genetic defects, you can transfer it in the next generation. That is again important. And that's why, and very rightly and very crisply, everything has been cleared. And congratulations, Veronica, for explaining all these things in a very, and that too in a very short time that you have.
Thank you, ma'am.
Thank
you. Thank you so much.
That was really
Thank you.
Thank you, ma'am. Thank you.
Thanks, Dr. Veronica. That was really very exhaustive scientific deliberation from your side, and we are very lucky to have you with us in our institute. For any genetic problem, we send all our patients to you, whether they're OBS or whether they're oncology or they're infertility. Thanks, Dr. Veronica, for excellent lecture.
Thank you so much for the opportunity.
Thank you, Chair and speakers for the session 2. And after thoroughly enriching 2 sessions with such pertinent talks, we proceed to our illuminant panel on IUI, the case scenarios, moderated by Dr. Deepak Goenka. Dr. Deepak Goenka is the Director of Institute of Human Reproduction, Guwahati, and had extensive training in ultrasound, laparoscopy, ART, and genetics. He's performing IVF since 1997 and successfully runs 1-year fellowship courses in reproductive medicine. Welcome, sir. I also invite our experts for the panel. Dr. Charmila Avayu, ma'am. She's Director, Aditi Hospital and Parvati Ayavu Fertility Center, Trichy. She's Consultant, South End Railway Hospital, Trichy. Vice President, FOGSI 2024. Vice President, Trichy OG Society. She has many, many accolades to her name. Welcome, ma'am, today. And also Dr. Rakhi Singh, ma'am. She's President NOGS, Vice President of UP State ISAR, Peer Reviewer for Journal of Obstetrics and Gynecology of India, and Chairperson of Endocrinology Committee, FOGSI, from 20. She has various awards, achievements, and publications to her name. And currently she's Director at Abalone Clinic, Noida. Welcome, ma'am. I request our esteemed moderator as well as experts to kindly invite and introduce the panelists for today.
Deepak, are you there? Or do you want the coordinator to introduce the panel members also? You will introduce the panel?
I can introduce, absolutely.
Okay.
Just because Ashwath sir name is there, so I'm getting inclined to introduce him. It's an honor to introduce him. In the first, Dr. Ankita, thank you for the kind introduction. It's a pleasure to introduce Dr. Ashwath. He is a world-famous diploma in advanced laparoscopy from France. He has diploma in laparoscopy management of advanced endometriosis from Austria, diploma in laparoscopic management of gynec malignancy, IRCAD Strasbourg, and fellow gynec oncology from GCRI. We all know him, how amazing surgeon he is. Not going to read up whole I think this is a very short CV for him. So let's not spend time on this reading short CV. He has much more things to applaud in his CV.
Thank you, sir. Thank you, sir. Thank you. Thank you so much.
Thank you, Dr. Ashwath. It's a pleasure. I don't know. I don't think we have ever met personally before, but I'm looking forward to meet you someday.
Thank you.
Dr. Jyoti Malik. She is a medical superintendent from JJ Institute of Medical Science, Director Root IVF and Fertility Institute, JJIMS, Vice Chairperson, Haryana Chapter of Indian Society of ISAR, Secretary, Haryana Association of Registered Obstetrics and Gynecology, Joint Secretary, Haryana Association of Gynec Endoscopy, Joint Secretary, IAG, Haryana Chapter, Secretary, IMA, Joint Secretary, Delhi Chapter, Founder President of Jajjar Obstetric and Gynecology Society, past Chairperson, Women Wing, Indian Medical Association, Haryana, life members of membership of various organizations. Welcome, Dr. Jyoti. Dr. Ikika Singh, she is Secretary of Mao FOGSI Society, Executive Member of UP ISAR State Chapter, Member of PAC Committee 1990, 2019, 21, Member FOGSI Young Talent Promotion Committee 2022, Member FOGSI Endocrinology Committee 2022, Member of ISAR IFS ACE FOGSI Consensus, paper and poster presentation in various national and international conferences. Welcome, Dr. Singh. Welcome, Dr. Raju Nair is also there in the panel, right, FOGSI?
Yes, Raju's there. Raju's, CV, he got late. That's why he could not introduce.
He doesn't need any introduction. Welcome, Dr. Sharmila and Dr. Rakhi. Dr. Sharmila, last, I think, 1 month back or 2 months back. I think we met recently only.
Yes, sir. Yes, sir. Thank you, sir.
I request
And
all
welcome,
panel
Rakhi.
members and expert to on their videos so that they will be seen. Others, please off the
Yes,
camera.
I can see Dr. Sharmila, Dr. Raju Nair, Dr. Swat. Dr. Rakhi is there or not? I'm not very sure.
Matlab? She's there.
Please on the video. Then you will see.
150 से
See,
नीचे
on करो.
देंगे देखो 3 lakhs का
No, please on the videos all panel members. Then it will be easy to
160 उससे नीचे बहुत मुश्किल हो जाएगा राजा, because I'll have to give the answer to the everybody also ना. हाँ हाँ.
Please on the video, Raki.
Down.
कि आपका वीडियो ऑन नहीं है, खाली ऑडियो दिखाई दे रहा है.
ये स्टॉल मिलेगा, अगर स्टॉल भी लेते हो तो 3 आता है वो. Work. She's planning for her conference.
I think without wasting much time, we can start. Rakhi will join us with a video on soon. Very, very basic panel discussion. No tricky question, no hi-fi. Where I am trying to keep everything very, very basic.
So can you make it slideshow, sir?
Yeah. I think all of you can see the slideshow.
No, sir, it is still in the other version.
I am sharing my slides.
So we can see your slides, but it is not a full slideshow.
Let me check.
Slides are moving, but not in slideshow.
Let me try again. Is it better now?
Just wait for
Deepak sir, you go to that slideshow and click slideshow above.
Yeah, this is what I am doing.
There's on the top also
Above
there is
above
one.
that above slideshow is there.
Near animations, there's one slideshow. Top.
Sir, it's an older version of Office. Slideshow mode may not work. Please go ahead.
Okay.
I think we can see the case number 1.
Yes,
we
sir.
can see, sir. We can see, sir.
Yes,
You
yes.
can continue. We can see.
Yeah. Mrs. A, 31-year-old, married for 3 years, primary infertility for 2 years, regular menstruation, normal BMI, normal AMH, and TVS and HSG is normal. The problem is basically the husband is azoospermic. Not going into the details of azoospermia, already we have heard about the details of azoospermia. This particular patient opted for donor insemination because of whatever reason. What we want to understand here today is in these cases where the female partner is 100% normal, should we go ahead with the ovulation induction or should we go ahead with the natural cycle IUI? Anyone can take the case.
Sir, what I do is that whenever the female partner is completely normal, I don't induce usually. I just do natural cycle IUI. When the female partner is completely, and it's a donor insemination. Okay. So I do natural cycle IUI for a AID. If the female partner is completely normal.
Something to contribute?
So I think I will go for an ovarian stimulation because the cycle is under my control. Better control. I know that the egg will form correctly, and only when the follicle is of appropriate size, I'll give the trigger. So that way for me, ovarian stimulation, I will do even if she's got a regular cycle.
I would also do ovulation induction with minimal amount of stimulation, at least.
Oral ovulation is more than enough.
That is what. Minimal only. Minimal stimulation also. That is correct.
with the IUI.
Okay.
Okay, now we can see you.
Yeah, can I speak?
Yes. Any other
Raju.
opinion? Any other panelist wants to contribute? Dr. Raju, you want to contribute something?
Yeah, basically for IUI, the chance of success for a single IUI is hardly 15 to 20%. So basically, infertility to increase the chance of pregnancy, always one thing which we can do is that increasing the number of follicles. So for natural cycle IUI, for a donor insemination, even though it's an accepted therapy, but the majority of the situation when patient is coming from the pocket, we want to increase the chance of conception. So a minimal stimulation with oral ovulations will be a better choice, and maybe a timing of ovulation with a trigger will also be sufficient, because then we can do it in a better way rather than going for a natural cycle. Even though nice guidelines and everything suggests a natural cycle like you for donor insemination, I prefer a minimal stimulation.
Any other opinion from any other panelist? Or everybody agrees that they want to go with what I understood from all the opinions, oral ovulations and IUI. Am I right?
Oral evidence trigger with HCG and IUI. Nothing else. Nothing else.
No HMG basically.
Yes. No.
Experts, they want to comment anything? Dr. Charmila has given her opinions. Rakhi, do you want to add something?
Nothing special, sir.
Rakhi, we can't hear you.
I said nothing special, sir.
Nothing specific. Thank you, Rakhi. Now, let's go to the second case. Mrs. X, 33-year-old.
Slide is not
married
moving, sir. Slide is not moving.
Okay, let me see. Where are we going wrong?
Now it has come.
Now
Slide has
moving,
come.
now moving.
Now moving. Deepak, sir, now slide is seen.
Some lag is there, I think then.
No problem. Slide is seen, sir.
Okay. Mrs. X, 33-year-old, married for 5 years, primary infertility for 4.5 years, regular cycle hypothyroidism or minimum thyroxine, AMH is 2.2, husband consumes tobacco frequently. See, here the catch is, semen analysis shows sperm count of 7 million with 40% motility. So definitely oligospermia with 40% motility. Should we suggest her for should we suggest a couple for IUI? What is the minimum sperm concentration we should look for when we advise for IUI? Very, very straightforward. Basically, I am looking for a cutoff limit. When should we advise for the male infertility? Any panelist. I am not pointing out to any specific panelist.
Actually,
and then lastly, we'll take the opinion of our experts.
Okay.
5 million, Sir Deepak, sir. I opt for minimum of 5 million.
So
5 million.
The mortal factor, the total mortal factor should be around 5 million, because in this patient the total count is hardly 7 million with mortality of 40. So when we watch the sample, your recovery won't be that great. So my take will be at least we should have around 10 to 15 million, then it will be better.
Somehow I am little confused now. Anybody wants to contribute something more? I am looking for something more.
See,
we are missing very, very important aspect here. Dr. Rakhi, please.
Sir, actually, according to the SRA guideline, there's no particular count or particular motility where the results will be seen. They're very clear on that. But when you have a total motile sperm count after preparation to be around, at least around 10 million, it gives you good, best results. But if you want a minimum, at least it should be more than 3 million total motile sperm count to have a better result with IUI. That's what the guidelines of SRA says. And but they have never said that, so this is very low, you cannot do this is quite normal, you can do. There's nothing like that. But they have just given a variation where you can work on that patient to try for an IUI, because IUI results are not going to be extraordinary just because you do an IUI in a patient who's regularly cycling.
I would like to add something. See, this patient, if she can afford, we can take her up directly for IVF. But if she is not able to afford, we can definitely give a trial. But one thing is there, which is husband consumes tobacco very frequently. And this tobacco is very notorious. At times, it can hamper the fertilization capacity of the oocyte and the sperms also. Even if the quality may be looking very good on it, but that answers we can get only when the IVF is done and the fertilization is seen for. That can be advised for the husband to restrict and stop alcohol and the tobacco intake, whatever the fertilization which it would affect. And she's hypothyroid also, so that's okay if she's been taking the cycles regularly. And if she had to conceive on her own, she would have conceived by this 4.5 years of infertility where she was naturally. So a short trial with IUI can be given, and do counsel the patient to move ahead for IVF.
You have to take in account of all that, as Dr. Raki madam told, take in account of all the features. See, her AMH is 2.2.
Yes.
Not only we take, no use of taking only the sperm count. That is my hypothyroidism,
a
low
holistic
AMH,
approach has to be
tobacco.
taken into
Everything has to be in total, you have to take, and then we have to decide to go for IUI or not, or send the patient for IVF. And if the patient is affording, she can directly go for IVF.
Very nice. So basically, we have multiple aspects to think about here. First thing I asked about the total sperm count at which we can advise for IUI. My question here was incomplete, and Dr. Charmila rightly pointed out two very important things she has added. Number one, we have to look into the count. We don't have to look only into the count, we have to look into the motile sperm also. So she used a very, very important term, total sperm motile count. To add to this, she also used after centrifugation, but after preparation. That's the best answer. Don't look only at the semen analysis report. Many, many times when we do the semen preparation, then initial semen count shows good motility, good count, but after the preparation counts may decrease, the motile sperm count may decrease drastically. So fully agree with ma'am that we should look into the total sperm count after preparation. Ideally, that should be somewhere between 5 to 10 million sperm count, motile sperm count should be there to get a optimum IUI result. And anything less than 5 million, we can definitely go for the IUI. There is nothing cut-off limit, but our chances of pregnancy decreases. Then Dr. Raki also added into the other aspects. We don't have to look only at the count to achieve pregnancy. We have to look for the other important aspect. Very often we ignore about the tobacco. Very sharply she catch the history here. Tobacco in any form, not only in cigarette, but any form of tobacco significantly decreases the pregnancy rate. Thank you both of you for pointing out very, very important aspect. Now let's go to the case 3. 32 years old, married for 5
you
years.
need to change your slides, sir.
I have changed. I think I've changed too fast. It will come back.
Okay.
32 years old, married for 5 years. AMH is 3. HSG TVS is normal. Semen analysis is also normal. Karyotyping and sperm DFI are also normal. So basically, it's a case of unexplained infertility I am talking about. So in a case of unexplained infertility, what's the role of IUI? Would you like to go for IUI, or because she is already married for 5 years, or do you want to go ahead with the IVF directly? Is there any role of IUI in such cases? Any of the panelists?
Yeah,
Dr. Nair.
In unexplained infertility, IUI definitely plays a role, even though number needed to treat may be little on the higher side. But before venturing out into IVF, we can definitely consider a gonadotropin stimulation with IUI, because once you stimulate with the gonadotropins, you may get a better quality oocyte, and the timing of ovulation can be a little more fine-tuned. So, along with a proper semen preparation, you can increase the cancer fertilization, so a pregnancy can happen. But definitely, since all other parameters are normal and the patient is not conceiving spontaneously, definitely we should look into the other parameters like oocyte quality and fertilization issues that will come only with IVF. or exceed, but IUI with gonadotropin stimulation definitely has got a role.
Anybody wants to differ? Because literature is very, very divided in these cases. Some of the literature, some of the evidences says absolutely no role of IUI, whereas some other literature says yes, IUI can be tried in these cases. So what do you people do in your routine practice, daily practice?
See, unexplained infertility, I usually try for IUI about 3 cycles with gonadotropin simulation. Then only I send the patient for IVF. So minimum of 3 cycles I will be trying with IUI.
Jyoti is here?
Yeah, good evening. Good evening, sir. Good evening.
Dr. Jyoti.
Yeah. Yeah, sorry to join late. I think discussing unexplained infertility. We are seeing only case 2 on the this thing on the monitor. I'm seeing the case 2 only. I think case 3. We are discussing the next case.
Yes,
So can you
I
just
think there is
change your
some lag
slide?
somewhere. Some lag somewhere. Don't worry.
Yeah.
Basically, we are talking about unexplained infertility and
Unexplained,
role of
right.
IUI.
Yeah, so unexplained infertility, definitely there is a role of IUI, and we have to at least try minimum of 3 IUIs because and if it is not working, then we go on to IVF. So though they say that directly also one can, if they have tried, we have still give the time, and IUI with gonadotrophins should be our first line of treatment. And if the 3 to 4 cycles of IUI have failed, then one should move on to IVF, definitely. IVF FOGSI.
Any opinion from anyone else? Any expert comments?
So we have to take the patient's choices under consideration. You have to counsel the couple because the success rate of IUI has to be told to them clearly. And when they accept, you can consider doing IUI for at least 3 cycles, because I don't think for unexplained infertility beyond 3 cycles we get better results. But at least for 3 cycles, we can give them the choice and then move ahead with IVF. She's not conceiving, but the patient has to be told very, very clearly the results and how it works. Otherwise, expectations do not be too much as far as unexplained infertility is concerned.
Okay, anything you want to add?
Raki?
He's
busy with the conference.
Let's go to the next question.
Change your slides, sir.
Advantage, I think everybody told advantage of this. There is a role of gonadotrophins also if you want to go ahead with IUI in these cases. Now, coming to the case 4, I don't know whether it is
Sir,
displayed
you
or
have
not.
to change your slides, Dr.
It's not moving,
I
Raki,
have
so
changed.
that's
I
why
think
sir
some
is.
lag is
It
there.
is not moving. It is on case 2 only.
Raki, he knows, but he's giving the questions by himself.
Okay, I will read it out. I made the questions very simple.
Okay.
Mrs. X, 30 years old, with history of oligomenorrhea. She gets her menstruation once in 60 to 70 days and is diagnosed case of PCOS. So basically here we are talking about a case of PCOS with irregular menstruation once in 60 to 70 days. She is already on metformin and planning since marriage. TVS classically shows the polycystic ovary, HSG is normal, semen analysis is normal. So basically here I'm talking about a simple classical case of PCOS with irregular menstruation. That's it. There is no other problem. I just want everyone to give a message how they stimulate in these cases.
Sir, I would like to know about hirsutism pattern, hyperandrogenism pattern, if it was there or not.
Minimal
Insulin
hirsutism is there.
resistance, how bad it was, and LH level, how bad it was, or AMH, where she was standing with the transvaginal polycystic ovaries, how bad the ovaries were, what was the volume. So that would give us the insight of how harder stimulation she would require. As it is, she has got the cycles of 1 in that is for 20 days, 2 months. So
right.
that itself is telling that she is having bad insulin resistance and hyperinsulinemia along with hyperandrogenism. BMI would matter a lot. Where we are standing with that BMI of hers, that would also give us the opinion. If it is BMI is less than 23, which is ideal for Indian scenarios. So that would give us a insight that she would be stimulated easily. And if her BMI is quite hard enough, quite higher enough, she would require to reduce some amount of weight, at least 5%, that is 2 to 4 kgs of weight. That would help in stimulation.
राखी बहुत सारी चीजें एक साथ आप बोल रहे हो, बहुत सारी चीजें एक साथ बोल रहे हैं। बेसिकली वेरी कुछ इंपॉर्टेंट थोड़ा सा डिबेट करते हैं थोड़ा सा यहाँ पे। हाउ मेनी ऑफ यू डू एलएच? सब few important information I have missed here. Okay, let's consider she has a BMI of 22. तो आपका जो इंडियन BMI के लिए हम बोलते हैं, what we speak about the Indian BMI is 23. Let's make it 22. How many of you do LH in all PCOS cases? I personally don't do in all PCOS cases. I hardly do in any PCOS cases.
I don't do.
I also don't do routinely, but if she is a lean PCOS, because she is not her BMI is 22, which is I think we don't need to do a LH for her normally, routinely.
BMI तो करते हो आप डॉक्टर सर?
I don't routinely do LH.
It's only done in some cases where the other parameters are also deranged and difficult stimulation is there in those cases. And
what cases you can do, otherwise let's not give a message, routine message कि सारे PCOS cases में all PCOS cases नहीं, we don't need to do.
No.
So let's give a lot of more than 400 delegates are there. That's very nice to see. So let's give them a very clear message. All PCOS cases doesn't require to do LH level. And stimulation protocol clay, you wanted to have a BMI. I gave you a BMI of 22. So yes, Jyoti, what stimulation protocol? The important thing is she's getting menstruation once in 2 months.
We need to give her ovulation induction. How long is she married? I missed.
She's married for
No. How long has she been married? Should we straight away go on to IVF, or should we give her this and give her a chance for IUI? That is what I wanted to know, the duration of marriage, the treatment she has been taking.
Let's not deviate. The couple decided that they want to go for IUI. So let's not talk about IVF. Our panel discussion is only about IUI.
About IUI. So we would be it is always preferable to go with aromatase inhibitors here, and letrozole would be the choice in cases of PCOS. So we would start with the letrozole from day 2 for 5 days, do the ovulation induction with this, and do the follicular monitoring, and accordingly see whether she is making the follicles are growing or not. And in the next cycle.
Wait, Jyoti, Dr. Jyoti, just wait. Dr. Ikika is there?
Yes, sir. Yes, sir.
Ikika, Dr. Jyoti has told us that she wants to go ahead with the letrozole for 2.5 milligram for 5 days, and she wants to call her after again on the 10th day of menstruation. Am I right, Dr. Jyoti? This is what you told us?
Right. So we'll call her maybe 7th, 8th. We give her to day 6 maybe, or day 3 to 7. What if we have given her, then maybe day 8 I would call her for a follicular monitoring.
She wants to call her, and my personal experience says on day 8 we will not see anything.
That's true.
True.
It will be baseline ovary only. So with such a minimal stimulation, with such a irregular menstruation, anybody wants to give some stronger stimulation or some longer stimulation?
See, such a patient, I usually start the patient with letrozole and gonadotropins actually, because as you told, it's a patient is not ovulating for like a periods once in 80 days or like that it is. So naturally, I will go for letrozole 2.5 milligram BED along with that recombinant FSH, because we have to anyway, we can do only 2 to 3 cycles of IUI. That is what we usually do. So whenever we do, we have to get results. So naturally, the follicle has to come. Either do with letrozole, BD, then do a scan. It is not growing, then start on gonadotropins. But I prefer to start letrozole and gonadotropins together. That is what I do.
I am more or less agree with Ashar because we have to stimulate the patient because the cycles are very irregular. So, letrozole 5 mg from day 2 or day 3 to start off, and then always add the recombinant deposits. Preferably, I avoid HMG during PCO patients, and we start at recombinant deposit 75 IU on day 5 and day 7, and usually call the patient for day 10. Because why I call the patient on day 10? Because by the time, suppose the patient is not showing a response, we can always add on with the gonadotropins. And if the patient is suppose already showing a stance of hyperresponse, we can always control the stimulation in the better day. So we should give a bit of stimulation before getting into scans on day 6 or day 8 because nothing will happen during the time.
So I actually totally disagree with both of them. I would give only letrozole, 2.5 milligram for 5 days, call her on day 10 for a scan. If there is no follicle about 10 mm, I would go for a stair-step protocol where I give additional dose of letrozole for the next 5 days and then call her for a follicular study after that. Many lean PCOS patients respond to an extended protocol compared to the conventional protocol for 5 days. And gonadotropins being given for a lean PCOS is going to cause a higher number of follicles to form, and she's got a higher chance of going for OHSS. So for a lean PCOS, I'd be extremely careful when I'm inducing her. And the first cycle will be my cycle to analyze what's happening with her. So I will not go into a higher dose or an extended protocol unless I know that she's not responding, because lean PCOS are notorious for going for OHSS.
That is very rightly said by Dr. Charmila, because this is the first cycle that we are trying to see what is happening actually, how she is responding. So right from first cycle, if we add gonadotropins, I think we may not be able to judge what we are dealing with. So in first cycle, if with a low dose she has not responded, maybe we have then different protocols. With letrozole, we may give extended protocol for 10 days, or we may give that step up protocol 2.55, 7.5, 10, or we may then use any of the protocols. And if even those protocols have not worked, then the third my step would be to add gonadotropins. That is what I feel.
And counsel for OHSS and IVF when you're doing a stimulation with ovarian with gonadotropins, because anytime she can blow up.
So we are planning for IUI. So hopefully this single agent therapy might have been finished once you plan time intercourse therapy. So once that process is over, obviously we are going for IUI that will stimulate better and better follicle growth. Hyperstimulation, as a fertility specialist, you know that with 2 doses of gonadotropins, no OHSS will develop. So you can be little proactive, and obviously when this goes literally haywire, definitely we have a control in our hand.
So this is very
already we would have if the patient, when we are planning to go for IUI, already we would have done, the patient would have done ovulation induction and the cycles would have done. Then only initial cycle, first cycle itself, we don't go for IUI. So this patient has been planning to go for IUI in this cycle, means already that Sharmila madam told patient would have taken 2.5, and that trial and all these things would have been over usually. So when a patient comes to you in the first cycle itself, you don't suggest IUI. So that is why when you are suggesting a cycle for IUI, then we want to get the follicles. That is why we put gonadotropins along with letrozole.
So we have very important things to remember in such cases of PCOS. Number one, these cases may be difficult to respond. Number two, important thing is if they respond, there is always a risk of hyperstimulation. And Dr. Aswath has given an input that there should be a trial cycle for such cases. Some of us are doing trial cycle, but I don't think all of us are going ahead with the trial cycle. First cycle as such is a trial cycle always in such cases, whether what medicines will work, what medicines will not work. Nobody can be 100% sure. As Dr. Jyoti very correctly told, and Dr. Raju also told in a similar line, the first cycle itself, only going for the trial cycle without doing an IUI, sometimes it may not be acceptable for the patients, and they go ahead with the IUI also in the first cycle if the medicines work. If they don't work, then we have to go with the second cycle or third cycle accordingly. But risk of hyperstimulation we have to keep in mind. All or none phenomena sometimes works in these cases. Either they don't respond or they respond very, very massively. At just for the, I know all of us are familiar, just for the benefit of the all the delegates, at what number of follicles in IUI, not in IVF, we should cancel the cycle. When do you cancel the cycle in the for the risk of OHSS?
More than
Very
three, if
simple
we
answer.
have 3 or more than 3 follicles, which are more than 16 we should not be going ahead with the IUI, and we should cancel that cycle.
Excellent,
3
Jyoti.
or
This is a very simple, straightforward answer. All of us must remember. Dr. Jyoti, for the benefit of everyone, just repeat it once, just in one line. Dr. Malik, please repeat it
if we
once
have
again.
3 or more because we are not 3 or more than 3 follicles.
Right. This is a very important message.
So, but
Don't
now
be
now Estray said more than
2
two of
right.
around 15 and
2
5 more than probably 10
14
10
More
more
than
than 5.
5,
5
10,
more
10
than
more
5
than
of 10, then it is you have to
5
cancel
and
the
10
cycle.
and
You have
Yes.
to cancel this.
right. Anybody still using clomiphene citrate?
No.
So one can use clomiphene
sometimes.
citrate. It is not contraindicated. One can always, I mean, it is not that we should not be using clomiphene at all. But there are cases where if the clomiphene has not worked, though it will give us multifollicular development, whereas letrozole gives a monofollicular development. But yeah, so but it does not mean that clomiphene cannot be used at all in cases of PCOS. We have to be careful, and that is how when we get multiple follicles, we don't go ahead. In cases
many
of clomiphene, there is more chance of canceling the cycles.
many times what I do is that if letrozole is not responding, sometimes we start on clomiphene, it responds. See,
Right.
you have made 2-3 cycles and the letrozole is not responding. Try a cycle of clomiphene, many times it responds.
Yes, that's true. Sometimes some patients respond better to clomiphene compared to letrozole. That's also we are seeing sometimes. And for unexplained infertility, clomiphene citrate is better,
Yes.
sir, because 2 to 3 follicles can form. It will give you much better results compared to a single follicle in that cases.
Yeah, I was looking for that unexplained infertility only. Because there are nowadays, all of us stick to letrozole, but clomiphene citrate is not completely out of picture. So in cases where letrozole doesn't work, in cases of PCOS cases, clomiphene citrate still plays a role. I don't know whether you can see this follicular study chart or not.
No,
Okay,
sir.
here
No,
I
sir.
have a patient. We have started with the IUI, and we found her on the day 10 of the day 10 of the stimulation. Her follicle size is 16 millimeter and endometrial thickness is 5 mm only. So basically, it's a case of little bit of asynchrony. Follicle is growing well, but endometrial thickness is only 5 mm, stimulated with letrozole 5 mg. So what can we do? Should we cancel the cycle or can we survive? Can we rescue this cycle?
Actually, for IUI,
Any
there
of
is
the
nothing.
panelists, मैं पहले panelist को बोलने देते हैं. Let us let the panelists speak, then we can contribute. Any of the panelists?
Sir, I didn't see that case properly. Anyway, the endometrium is not developed, and the follicle is developed. That is what you have told.
Right.
Okay, Deepak sir, the follicle has developed and the endometrium is. So 2 ways. See, in an IUI cycle, it is difficult, but what we can do is that you can put the patient on an antagonist and wait for the endometrium to grow. Well, otherwise, what endometrium to grow, you can give some estradiol valerate and all this is by the time for the endometrium to grow. That is what we, otherwise the follicle will be and the disparity will be continuing. That is why.
Any other opinion from any of the panelists?
We can wait for the follicles and we can cross check an E2 level so that we can see whether adequate estrogen is there and the endometrium is not growing. So we'll have a better correlation.
Ma'am, we have received 2 suggestions for this patient. One suggestion we received is we can add antagonist, But here the question comes, the how long we should give antagonist, because follicle will keep on growing, antagonist will just prevent the ovulation. And second suggestion we got that we can add estrogen. Any suggestion from you, ma'am, now?
When the endometrial thickness is not in synchrony with the follicular growth, either the follicle is not of a good quality and that is not producing enough estrogen. So even if you give estrogen, the endometrium may look okay, but the implantation may not happen. So it's better that you cancel the cycle and go for a fresh cycle and try out a different protocol to get a good follicle with a synchronous endometrium.
Basically, we have to look into two aspects. Number one, as ma'am told, endometrium, most of the time, it is a reflection of the oocyte quality. If the oocyte quality is poor, it will not secrete the sufficient estrogen and endometrium will be poor. And second, it may be a case of poor endometrium, thin endometrium, that we will come to know only after the second stimulation with some other protocol. We have to look into the AMH, we have to look into the age of the patient.
Hyperandrogenism also.
Hyperandrogenism also. So we have to look at the other aspect. And if everything is all right, then it may be a case of poor oocytes. Or otherwise, these are only two possibilities here in these cases. And both the possibilities we have to explore. Giving exogenous and estrogen or giving exogenous and antagonist, sometimes you may save the cycle, but our ultimate target is to achieve pregnancy, not to complete a cycle. So getting pregnancy, we will fail in these cases. So cancellation is definitely a valid option in such cases. Again, this is just a repetition of the previous talk. In IUI preparation, when should we go with the swim-up method and when should we go for the density gradient method? Dr. Ikaki, I would like to have your opinion. You have been very silent. She is there.
Raki?
Hello?
Raki?
Yes. Yes.
What type of sperm preparation you prefer for
I
IUI?
would prefer swim up technique. I don't want to give all the centrifugation to the patients as much as possible. I would like to avoid it. And if suppose we have to do it in the semen samples where there's a lot of debris and all that, then definitely we'll have to do it. But swim up is my favorite one because that would give us, but in that also, in the swim up technique, again, we should have a good number of sperm count and a good volume of semen sample that would give us a good result for it.
Opinion from anyone else? Dr. Aswath, what do you prefer?
And as Raki madam told, if you have a good sample, sim up is otherwise I usually prefer to do a density gradient actually. Density gradient method. So the quality of the sperms which we get will be better. That is what I feel. So most of the time in my practice, I have enough number of IUI. My practice, I get better results with the density gradient. I don't know of others actually. Better result many times with the density gradient method.
What do you prefer in your practice?
I prefer density gradient in my practice.
Dr. Sonia Malik?
Jyoti Malik.
She is... Yes,
The
ma'am.
density gradient is always the better one. It is the most commonly used. Swim up is when the sperm count is good. So, and if it is, then we just allow swim up if the count is, if it is a sample. And if the count is on the lower side, then density gradient would be always better.
Deepak sir, what in simple terms, if the patient with unexplained infertility, I go for sim up. That means everything is normal. If the patient with the oligoastenospermia, I just go with the density gradient method. That is what I prefer to do.
What do you suggest?
Sir, it doesn't matter actually. But as Ashwat sir said, when you have the two different methods being done, probably for the better sample, a swim up is quite enough. You'll get a sample which has got less of fragmentation and all that. But when you have a poor sample, it's better to go for centrifugation. density gradient.
So basically, not much of difference.
No
The
difference.
consensus are more or less clear. If the sample is good, semen sample is good, we can go ahead with the SWIMUP method. But if we see any pathology in the sample, we can shift to density gradient method. We must remember density gradient is slightly expensive than the SWIMUP method. And most of the time, our patients are not concerned what method we are using, and we don't charge separately for both the methods. So laboratory may spend some unnecessary extra expenses whenever they are using the density gradient. So end result is not much of difference. People may disagree with us. Next is 40-year-old. Here our patient is little elderly, married for 2 years, belongs to low socioeconomic status and cannot afford IVF. So let's not talk about IVF. Her AMH is also very low, 0.65. Remaining all the investigations are normal. BMI is normal. So basic problem here is late marriage with low AMH. Elderly patient, late marriage with low AMH. Should we advise her IUI? But if the couple wants to go with IUI, what induction protocol would you like to use and what precautions do you want to use at this age? Elderly patient, late marriage, low AMH, is planning to go for IUI. So any specific induction method you want to have for this particular couple?
So here we would like to, along with the ovulation induction with the oral ovulagens, we should always also be adding gonadotrophins here because of low AMH, because of her elderly age. And since though ideally speaking, this patient is a candidate for IVF, and in spite of low AMH and elderly age, we with IUI the results are not going to be good at all. So with a lot of counseling, it has to be told to them that I mean with ovulation induction, with adding gonadotrophins and giving at the most 1 to 2 cycles of IUI only, we should try. Otherwise, she should move on to IVF as early as possible, because anyhow, we are not benefiting much by waiting, and the AMH is going to fall with more and
Calm
more
down.
the time that is being lost.
Definitely this couple is not ideal case for IUI, but because of her financial status, she cannot afford to go for IVF. So she wants us to try for IUI. So anything else anything more we can do for her. One thing you told
We
me,
can
we
even
should go ahead with the
start giving
gonadotrophins.
her. Yeah, we can also add CoQ so as to improve her oocyte quality. We can add the DHES. So these are a little just to improvise the oocyte quality. Maybe these are some adjuvants that can be started along with our, though we need to give them for a longer time. It is not just that particular cycle they are going to help, but maybe we can start with CoQ10 and DHEAS in the cycles that they are coming for the consultation, and they can along with that 1 or 2 cycles of IUI only with gonadotrophins.
Any input from you?
What can I say?
Yes,
but you said low socioeconomic status. If she's been affording, I would actually prefer a purely gonadotropin cycle. And probably that will give a better follicle, because that 2 years of infertility is an advantage for her. She's not a long period of infertility. Planning a pregnancy only for the past 2 years, probably a purely gonadotropin cycle may benefit compared to using an oral ovulation, maybe. And probably she'll get more follicles also compared to giving an oral ovulation.
Dr. Lakhi, you want to add something?
Sir?
Basically, as we are discussing, we all understand this is not a right candidate for the IUI. But we do get in our day-to-day practice couple where they cannot afford with the IVF and they want to try something, kuch to try kar do. So in these cases, IUI can be attempted. It's not that they are absolute contraindication for IUI. In rare cases, in some with proper counseling, IUI can be tried, as Dr. Jyoti told. In these cases, we can wait because she is married for 2 years and it is already too late. Waiting for another 2 months or 3 months or 4 months is not going to make much of the difference in their AMH level or in their age group. She is already 40, AMH is already low. As Dr. Jyoti told, okay, we can add some CoQ enzyme or DHEA and we let them try naturally for 3 or 4 cycles with these medication. After 3 or 4 months, if they don't conceive, we can go ahead with the IUI. And by the time, if even with IUI, if they don't conceive, then they have to accept it that they have to go with IVF only if they can afford. So it's not that there is absolutely 0% chances of pregnancy. No, some enthusiasm from our side is also required. Though we understand the chances of pregnancies are very, very less, still can be attempted.
We can never say no to any patients. Many
Yes,
times
exactly.
at 40, with the minimal stimulation, we have seen conceptions. Make it a shorter trial, not for a long period of time.
Yes, and don't make it very expensive for the couple, in this couples.
Yeah.
Okay, I think we don't have much time, only 30 seconds. Just wants to go shift to the with ART rules about the. So let's have my last slide. If a single woman wants to go with the donor insemination, this is the last question. After that, we will conclude. A single woman wants to go with the donor insemination, and the single woman, I mean, there can be 5 situations in this part of the country where I live. I come from the northeast part of the country. We have seen all types of patients. Unmarried girls, what are the legalities? Can we do IUI, donor insemination, for unmarried girls?
Yes, yes, yes.
Divorced?
Yes.
With the divorce paper she's having, you can do. Separated, don't do.
Unmarried also, we have to have a affidavit that she is unmarried without any living relationship.
Age
That
should
is
be
very,
more
very
than
important.
21 at least, because that is the minimum age that we can give them infertility treatment. Age should be more than 21.
21. Take care. But basically, unmarried girl can go with IUI with proper affidavit, with a proper declaration. Divorce with a divorce certificate. Widow. Can we go ahead with IUI in widows?
Yeah, you can. She's a single woman.
She is a single woman. Says can be done. Abandoned. Husband has abandoned, and abandoned means not formally divorced, but living with someone else.
No.
No,
They
you
know
can't.
the whereabouts of the husband.
No, you can't.
We cannot do it.
You cannot do.
They are not formally divorced, so we cannot do. What about missing husband?
No,
Husband,
don't do. No,
We cannot do. We cannot do.
You will be missed. You can't.
So no divorce, missing husband and all we cannot do.
No.
Yeah. So basically, in unmarried girl, divorce, widow, we can go ahead with the proper documentation. Abandoned, when the wife is abandoned, but we know about the whereabouts of the husband, still we cannot do. Without the consent of the husband, we cannot go ahead with the donor insemination if the marriage is still valid. And missing husband have their own protocol of the missing, when to declare it for the dead, 7 years of missing, and then all the legal formalities. Once it comes into the widow category, then only we can do. Otherwise, even in the missing categories, we cannot do. Before I conclude, I would request my experts to give a concluding statement and give a carry-home message.
So the thing is, as you mentioned in all your case scenarios, be very clear about protocols. Don't bypass protocols, because then the problems both in the management as well as the medico-legal issue starts as far as ART is concerned. So be very, very clear in your protocols when you're doing that. And any youngster should do that, because we're seeing they cut corners and they get caught with problems. So, and always assess the mother's medical condition before you do any ART treatment. A mother who's hypertensive, not on lots of medications, a diabetic who's not controlled, just infertility treatment is not enough. A metabolic condition needs to be taken care of. That has to, because people think you make her pregnant and everything is fine and they shift her to another center. That should not happen. Total pre-conception care should be done.
Very important carry-home message. We don't have to look only at the infertile patient. We have to look into the fitness of the patient also.
Yes.
Dr. Rakhi, any concluding statement from you?
Rakhi, you're muted. Rakhi, muted.
Yes, Chamila.
Sir was asking for a take-home message.
Yes. The take-home is basically to do all the investigations properly and treat the patient, not hurry up for doing, taking up the patient for IVF. That is and never jump for increasing the doses of gonadotropin in any of the IUI patients. Be patient enough and the follicles will definitely come. Second point. And the third point is that restrict yourself and not do IUIs for any patient where the follicles are more than 3 of 6 mm, what we had
Dr.
taught.
Rakhi. Thank you, Dr. Rakhi.
Yeah.
I would like to thank all my panelists for a wonderful panel discussion, for all your inputs. Thank you, the organizers, for giving all of us this opportunity. Thank you, FOGSI, for making me do this today. Thank you all. I think we are within our time limit. Thank you all once again.
Thank you. And thank you, our moderator. Excellent panel.
Thank you,
Good
sir.
questions.
Yes,
Carry on, take home message. Thank you, Deepak sir. It was nice to be with you in the panelist.
Thank you. Thank you, Deepak. Deepak, we were classmates in PG, and it was even, I think, his knowledge in andrology is so deep. Even before PG, he had finished andrology training from Monash, and that is of the long experience. And when this topic was thought, I thought he is the right person to give insight into that. Thank you, experts, and thank you, panel members also. Over to Ankita.
Thank you, one and all.
After the break,
Thank you, sir, and everybody for giving us the opportunity. I would like to request, I'm standing for Vice Presidency of FOGSI, and this year is the elections in August. Kindly do remember Dr. Rakhi Singh from North Zone. Thank you.
thank you, ma'am. After brainstorming session of the panel, we would go ahead and request the tech team to please post the day 1 post-test MCQ link in the chat box. So we start the timer for 10 minutes. We have 20 questions for post-test. And also please display the QR code for the same. We have 10 minutes for 20 questions. Here is the QR code.
Can Nidima or Shreya explain? It is a Google form, no?
Yes, sir. Yes, sir.
It's Google form.
Yeah.
Scan the QR code or the link, and you can answer that.
Yes.
I got 10 minutes. 20 questions in 10 minutes. Simple questions. Please make Parax our co-host.
Done, sir.
Hello, Fesi.
Yes, sir.
Yeah, hi. I'm driving my way to the hospital, so I thought I'll just thank everyone for joining. We have 400 delegates who joined today. I am sure the course today was useful, and special word of appreciation to Dr. Facey Lewis, who managed the first day today, along with Dr. Ankita. So hope to see you all tomorrow at 4 o'clock for the second day with some new topics, more experts, and some wonderful interaction. So I take your leave and see you all tomorrow at 4 o'clock.
Okay. Today's coordinator.
Speci, after everything is done, you need to share the answers which you or Ankita or one of the coordinators,
Yes.
so that people understand the answer words. Right?
Okay.
So much, and I'll see you tomorrow.
Okay. Thank you. So try to finish fast. We have got 2 more minutes. Thank you all. I hope all have submitted.
Yes, ma'am.
Display the answer.
Yes, ma'am.
After we discuss the post-test, if you have, you can discuss the questions with the faculty. If they are around, we can try to solve that. So I request coordinator Dr. Angida to read the questions with the answers.
Yes, sir. The first question is, a patient with azoospermia has normal testicular volume, normal FSH. Which genetic abnormality is most likely? The answer is CFTR gene mutation. Second question. Hello?
Yes.
Am I audible? Yes. Second question, in non-obstructive azoospermia, microtizase sperm retrieval success rates correlate most significantly with whether it's high serum testosterone, larger testicular volume, lower FSH levels, or presence of varicocele. Answer is larger testicular volume, option B. Third question is, which sperm parameter has the highest predictive value for successful fertilization in ICSI? Whether it's sperm concentration, sperm motility and morphology, sperm seminal volume, or semen viscosity. Answer is option B, sperm motility and morphology. Fourth question, what is the optimum timing for performing microtization ICSI cycle? On the day of egg retrieval or 1 day prior, 1 week before egg retrieval, immediately after ovarian stimulation initiation, or after embryo transfer? Answer is option A, on the day of egg retrieval or 1 day prior. Question 5. Semen analysis should be repeated after a gap of 1 month, 3 months, 6 months, or none of the above. Answer is option A, it should be repeated after 1 month. Question 6. Minimum semen concentration according to latest more than 10 million per ml, more than 16 million per ml, more than 20 million per ml, or more than 5 million per ml? Answer is option B, more than 16 million per ml. Sperm vitality can be seen with eosin nigrosin stains, HOS test, none of the above, or both the tests. Answer is option D, both of the tests. Question number 8. Sperm DNA fragmentation test is included in basic semen test, extended semen test. It is not included in any semen test or advanced semen test. Answer is option B, extended semen test. Question number 9. Which is the most important investigation to distinguish obstructive from non-obstructive azoospermia? Whether it's FSH, LH, serum testosterone, or TRUS, transrectal ultrasound. Answer is option A, FSH. Question number 10. Sperm retrieval rate in AZFC microdeletion is 25%, 50%, 70%, or 0%. Answer is C, 70%. Question number 11. Why is semen preparation needed for IUI process? Whether it's to obtain a pellet with good spermatozoa concentration, for removal of seminal plasma, for higher proportion of motile sperms, or all of the above? Answer is D, all of the above. Question number 12. What is the significance of centrifugation in semen processing? To kill sperm quickly, to kill abnormal sperm, to concentrate the motile sperms, or to change the sperm motility? Answer is centrifugation in semen processing will concentrate the motile sperm. Option number C. Ideal centrifugation speed is 300 to 600 G. Option number C. Question number 14. What is TMSE? Whether it's total motile sperm super concentration, total morphologically normal sperm concentration, total motile sperm concentration, or all of the above? Answer is option C. TMSE is total motile sperm concentration. Question number 15. Which of the following gene mutations is most commonly associated with congenital bilateral absence of vas deferens in males? AR gene mutation, CFTR gene mutation, NR5A1 mutation, or FMR1 premutation? Answer is CFTR gene mutation. Question number 16. Most common chromosomal abnormality associated with severe male factor infertility, azoospermia and severe oligozoospermia is autosomal balanced translocation, Robertsonian translocation, Klinefelter syndrome, or AZFC microdeletion? Answer is most common chromosomal abnormality in severe male factor infertility is Klinefelter syndrome. Question number 17. Does addition of GnRH antag increase pregnancy rate in IUI cycle? Answer is A, yes. Question number 18. Which genetic syndrome associated with male infertility is also characterized by anosmia? Whether it's Klinefelter syndrome, Noonan syndrome, Coleman syndrome, or Prader-Willi syndrome? Answer is in male infertility, anosmia associated with Coleman syndrome. Does addition of gonadotropin increase pregnancy rate? The answer is A, yes, it increases pregnancy rate. Question number 20. If there are more than 3 follicles at the time of trigger in IUI stimulation, whether you will cancel the cycle or you will give trigger? Answer is option A, cancel the cycle. These are the answers to the 20 questions.
In the what noted in the question number 1, there was a slight error. It is non-palpable was. It was. It is typed as palpable was. And that's the most accurate. But even if it in non-palpable was, it is I mean, non-palpable was is the most, there is some small error in the question number 1. Nilima, if no other things, this can we wind up the session? And the repeat semen analysis has to be done minimum of after 1 month. You can do any time, but minimum gap has to be 1 month.
Sir, if there were any questions, we can wind up.
Okay. I think, first of all, let me thank the ICOG, especially the ICOG chair, Dr. Parag Biniwale, and the secretary, Dr. Sarida, for this wonderful initiative of having the certificate course. And actually, they started planning about 1.5 months back, and selecting the speakers, selecting the all the faculty for this. So I think, and also the FOGSI president, Dr. Sunitha Tandulwarkar, for this all the support and guidance is given to this initiative, and especially today, I think the next 2 days we have Dr. Seema Pandey and Dr. Pradeep Tambe, other conveners, and Dr. Seema is traveling, that's why she could not join today. Dr. Pradeep joined today, and today's coordinator is Dr. Srivastava. Let me thank for her for all this wonderful coordination and meticulous way she has done. And I like to specifically thank all the speakers, especially Dr. Chaitanya Shambedkar, Dr. Kedar Ganla, Dr. Krishna Chaitanya, Dr. Kunjumoidin, and Dr. Veronica for their excellent talks. I think all were as good, right to the point. And also the chairpersons, Dr. Nimish Shale, Dr. Anju Soni, Dr. Rakna Agarwal, and Dr. Leela Vas, and Dr. Mala Srivastava for this wonderful guiding both the sessions. And, lastly, I want to thank Dr. Deepak Goenka, who did a simple but to the point what we needed to know about the different case scenarios about the UI with experts like Dr. Charmla and Dr. Aki.
So the signal is gone.
Yes, I think Ankita ma'am, sir. Network is in,
He's back, I think.
Yeah, okay.
I'll just call him.
Okay, in between I got disconnected, and also especially Nilima and Sreya for this for the excellent coordination with the speakers and coordinators, and for sending the link everything in time. And I think this continue logging next 2 days also, then only you will be receiving the course certificate and you have to participate in the post test also. Thank you for all for joining. Thank you, Dr. Ankita also.
Thank you, sir.
Again.
Thank you, sir.
sir. Thank you, sir. Shreya, stop the recording and close the meeting.
Yes, ma'am.